Come on. There we go. All right. Okay, so we're gonna start today. We're gonna talk about class and clinical. We're gonna get you up and running. I'm gonna give you a lot of information and a lot of there's some dates that you don't have that you're going to have when I give them to you. So have a pencil and paper handy. So first things first, you don't have your clinical schedule because it's been a mess. And I don't like it that. This is the first time ever that I haven't had it out a week ahead of time. So believe me, I'm perturbed. Long story short, we lost one of our clinical sites. We don't have Central Florida SeaWorld as a clinical site because we don't have faculty to go there. So the good news is everybody got the day they requested. I was able to give everybody the clinical the day they want, but clinical is going to be a little different. It will be the majority of the time at South Seminole in Longwood with Ryan Gabon, and that'll be for everybody. Everybody will be rotating. Questions on that?
What were the times for South Seminole again?
He's doing 10 to 6, 10 a.m. to 6 p.m.
Yes, that is so much better than 1 to 9.
Yeah.
Is it every day that we like signed up for?
It is. Okay, so we're going to talk about that in a second, but it basically comes down to 6 days. You will have clinical just for 6 days out of the 11 or 12. But you also have some simulation in there. So 6 days you'll physically have to leave your house, comb your hair, and go to South Seminole. It is 72 hours of clinical, so it's double what we did for public health. So it is challenging. But to answer your question, you're going to have some days off, yes. I will, when we're done today, I will post the clinical schedule and I will post the simulation schedules and give everybody enough time to take a look at it. Plug it in your calendars, make sure there's no major conflicts, and we should be good to go. I didn't want to do that before class because no one would ever listen.
Dr. Green, don't we have to go to Seminole Health Department again or no?
No, we're not.
Okay, so it's just picnic project?
Yep.
Okay.
Unless they happen to be there. If health department happens to come one of our days, give flu shots or COVID vaccines, we can participate in that. No, we do not need to go back to the health department. So again, as Melissa just said, we all have a 4-hour shift at the picnic project again. That one, because it's a Sunday, I do let you complain about. So if you have a conflict or you're getting married that weekend or whatever it might be, try to find somebody to switch with you. If not, let me know. But it's really, it's 4 hours for one Sunday. And I did post that one the other day so that people could look at it. I haven't had too many complaints yet. So I hope you enjoyed the picnic project. They're missing us. So we'll be going back in smaller groups and we'll be focusing more on mental health issues. We'll be doing some depression assessments with people who want them. We're not going to force it on them. If they would like to talk about depression or loneliness, even chemical dependency. So we'll be dealing with more. We'll be doing our usual blood pressures and stuff, but we'll be dealing with more mental health issues. Right.
And did you say that the only location is South Seminole?
South Seminole, and some people are going to Right Choice Daycare Center who has not gone before.
Okay.
So a total of 6 days. Everybody got a total of 6 8-hour days. So
Okay.
some of you got 6 days at South Sem, some of you've got 5 days at South Sem and 1 day at Big Choice. Okay. We have 6 hours of sim. So there'll be 3 simulations at 2 hours apiece. At this point, they're all going to be remote, so we can do them from home. There is a new faculty that has been hired to do that. So you will be meeting her. Her name is Patty. And you'll have Patty and me or Patty and Miss Vogel on those simulations. You're going to meet a new person.
So the sim will be online, not in person anymore?
Not in person at this point.
Oh, okay.
So my understanding right now is everything is going to be remote except for ATI. Is that what you guys heard?
Yeah,
Um,
we heard.
So
Okay, so
our needs labs, they said that like first week is going to be online definitely, but they said next week might be in person.
Okay. All right. I believe we're gonna be remote. I'm pushing for remote, so. I don't like leaving the house anymore. Tests will be, as far as I know right now, our first test will be remote. We'll be doing it from home, so. Any other burning questions? All right, get your pencils out because this is something you need to write down. Sending it through chat. You all have to do a training which is called EPIC, and it is through Orlando Health for South Sem. It is an 8-hour training, which sounds like torture. It's an 8-hour training that you all and Ryan have to go through. It is going to be remote. You don't have to come to campus for it. But its attendance is going to be taken periodically during the day. The only time Orlando Health could do it, the first part of it's going to be next Wednesday. So 1 week from today. So instead of having class next Wednesday, you will be doing the EPIC training. That'll be 4 hours that day. And then you're going to finish up on Friday, the 29th from 8 to 12. Ms. LaRoche tells me you have something in the afternoon, but not in the morning. So it'll be a long day for you, but it counts as clinical hours and it has to be done for Orlando Health Clinicals. So any questions on the training? Anybody have you been through it?
No.
I've seen it.
Sounds very boring.
Will we just like get a link, like an emailed link or something to know where to find it?
Yeah, we'll get that out to you before next Wednesday.
What was the time for next Wednesday?
12:30 to 4:30. So you'll have a very short period between research and when the training starts. You'll be done at 4:30. So there'll be no official class next week. It'll just be the training. And then the other half of it will be the Friday from 8 to 12, 8 a.m. in the morning till 12 p.m.
The second half, is that on the 29th?
Yes.
I think we have a lab that day.
They told me that you don't start till 1, so it shouldn't overlap.
Mine
Yeah.
says 12:30.
We
Yeah,
do have
so
a
they
lab
split
that,
us into 2 groups. So the first one's like 8 to 12:30, and then the second one's 12:30 to 5 for lab.
And that's
Said we
that's
might
remote,
this.
right?
Pardon?
You're doing it from homes, right?
that's the one that they said might be at school.
It says like on our syllabus or like the lab day sheet, it says on campus.
Okay. I'll double check with Miss LaRoche, but she didn't think that was going to be a problem. My guess is it'll still be remote. Or if you're in that early group, you might have to come to campus and do do your training and then do your simulation. But I will double check with her. This is something coming from Orlando Health. It's for all your clinic. It covers all your clinicals. We just volunteered to let them have some of our clinical hours to get it done. So I will check that out though. Any other issues?
I have a question about the class schedule. I know you haven't been over it yet. I noticed that we're supposed to have 12 weeks in the quarter, correct?
The 12th week is finals and makeup. Yep.
I noticed that it's actually on week 13 that our final is scheduled on the 13th of April.
Did I do that? I will take a look at that, Taylor. I've been known to make mistakes. So that's your vacation week. I'll take a look at that.
Okay.
Yeah, it'll definitely be the week before. And I did not see a schedule come out from administration as far as when your finals were going to be. Did you guys get one? Like when the mental health ATI is, when the OBP's ATI is, that sort of thing.
I haven't seen it. I don't know if anyone's released it to us or not.
Okay. I wanted to make sure I wasn't going crazy because I looked for it and I haven't seen it. So I'll ask for it again. Traditionally, mental health has been on that Tuesday of finals week. We usually
Actually, yeah, I did see it because I have it right here on my planner. I have it for April 6th, same day as the final. I can't hear you. It broke up.
Is it a Wednesday or a Tuesday?
A Tuesday.
Okay, yeah. The final would, thank you for verifying that. The final would usually be one part of the day and then the ATI would be the other part. Okay, so plan on, yes, you don't have to come to school, Taylor, on your vacation. I will change
No,
that.
you know, it actually was my fault. I'm looking and I accidentally wrote the wrong date. So it wasn't you, it was me.
All right. That's all right. I'll make a mistake too. Don't worry. All right. Any other burning questions? All right. I'm going to bring up a PowerPoint. So we're going to do a little orientation to this class in clinical. If I ever disappear and stop talking, I probably have got kicked off my computer. My computer's not terrible, but once in a while it just like the internet shuts down for absolutely no reason. So don't worry, I will realize eventually that nobody's there and I'll come back. It's happened a couple times. All right, so this is 439. Clinical is actually NUR 436. So you have, if you haven't noticed yet, you have 2 Canvas classes on your dashboard. One is clinical and one is class. And it's actually, the numbers are opposite what your public health is, which makes it crazy. So public health, the clinical was the higher number. And mental health, it's the lower number. So I control both those courses in those sites. So if I'm announcing something that's really important, I try to put the announcements on both pages. I do use announcements a lot, and it'll probably annoy you, but try to keep up on them as much as you can. It will benefit you. However you get them.
Quick question. It says the exams are 3 p.m. I didn't understand that.
They're due to be done by 3 p.m. students. They'll be 1 o'clock in the afternoon, but they'll be an hour exam, so we'll be done by 3 p.m. Does that make sense?
Thank you.
I have to put like a time frame in there in case we have computer problems. Yeah, all exams will be starting at 1 p.m. Except the finals, the very last. Yeah, it's weird. The way you have to set the computer sometimes, it gives you all kinds of weird information. So announcements are important to me. If you don't have a cell phone in your phone yet, please make sure it's in there. I communicate a lot through text. I have no problem with that unless I'm sleeping. I won't hear you anyway, but you're always welcome to text me. I'll answer you as soon as I'm awake. I do answer email at least once a day, but if you need me immediately, don't hesitate to bother me. That's what they pay me for. Okay? If you got any issues, call me. My office on campus is, I think it's room 121. It's the one near the bathroom and the simulation lab. And we're not there much anymore. So, and for those of you that know me, I'm not going to have set office hours, but I'm available to you at any time. If you want to meet, we've met on Saturdays, Sundays. I mean, we can meet whenever you need to. Make an appointment. Okay. All right. Questions on any of that information? Okay, beautiful. Let me tell you a little bit about myself in case you care. And we kind of got to know each other a little bit, some of you more than others in public health. But let me tell you a little bit about myself and what I have to offer you as far as this lab. I went to nursing school in 1980s, early 80s. I was on the 5-year plan because I fooled around too much one year. So it took me 5 years to get through get my bachelor's. And I graduated from the University of Brockport in New York with a double major in nursing and psychology. We had jobs at that time. We had jobs before we graduated, just like a lot of our alumni do now, actually. So it was stressful because I had a job offer, my dream job, but you had to take the board. You had to wait 3 months for the result. You had to wait for it to come in the mail. So it's not like it is today. You guys you can Google it within 48 hours or whatever it is. And they let you start working back then. So got a dream job, University of Rochester, in Rochester, New York. I worked on a mental health unit. Absolutely loved it. Was working nights, probably in charge of nights, probably within a month or two of graduation. And I stayed there for a long time, over 10 years. While I was there, I got my master's degree in psych mental health nursing. I am not a nurse practitioner. And the reason is, when I went to school, there were not nurse practitioners. They were called clinical nurse specialists. So I'm what's considered a clinical nurse specialist in mental health. What I learned was psychotherapy, group therapy, a lot of different higher level interventions that we'll talk about. But I cannot prescribe. Anything else I can do, and that's fine with me. A lot of people from my cohort went back and did like postgraduate work to get their NP. And I started it, and then I decided to get my doctorate instead. So University of Rochester, worked there, went to school there. It was free tuition. It was awesome. And then I got a job. With the state of New York in 1991. I was a single mother of 6 children, and my kids were running wild. I was working evenings. My kids were running wild. So I decided I needed a daytime job Monday through Friday. And I found one at the state of New York, the state hospital, on a chemical dependency unit, and I loved it. It was Monday through Friday. My kids still ran wild. They didn't change at all. But I enjoyed the job change. And eventually, a couple years after I started at the state hospital, I moved over to the forensic. The forensic is the criminally insane. People who have a mental illness, who have committed a crime, and they're basically being held there. That's their sentence, is to be institutionalized at this place. So I was there until 2013, when I retired and moved down here to Florida. So great career. It was awesome. And in 2008, I went back to school because I was bored. I went to St. John Fisher College, which is in Rochester, New York, for their DNP program. It was a 2-year program. There was 8 of us. All of us were working full time. And we went to school every Friday night and all day Saturday. And it was pretty cool. Loved it. Actually didn't want to graduate. I was having so much fun. But glad I did it. And then I ended up moving down here to Florida to take care of my in-laws. So before you met me, I was working full-time at Bethune-Cookman in Daytona Beach. Loved it there. I started to work for ECPI part-time. And then my father-in-law has been ill the last couple of years. So I gave up my full-time job. And so I'm now just belong to ECPI, which is just fine. Also in the middle of that, for moving to Florida, I worked for about 6 years at Halifax Hospital in their children and adolescent behavioral health as a per diem. And I hated that job, and just left there probably 6 months ago when COVID started. Between COVID and our new nurse manager was 12-hour shift, more shifts and all that jazz. So it was time to say goodbye. But I've had a great career. Don't regret anything. They told me when I got out of school in the 80s, you should get a year of med surge, just like we're hearing now. I said, absolutely not. It's not my thing, and I'm not torturing myself for a year. I was also 9 months pregnant. I don't regret that at all. I'm not the best med surge nurse, but that's okay. There are med surge nurses who can't do psych. So technology changes so much. I would have had to relearn anything anyway. Any questions about any of that?
No. How old are your kids now?
I'm sorry?
How old are your kids now?
My children?
Yeah.
They're still crazy. Yeah. They're 24 to 34. I have 4 boys and 2 girls and a stepson. And I have 5 grandchildren and a new one coming in July. My baby's having a baby in July. So that's a big deal. They're awesome.
Why psychology?
Huh? What?
Why psychology?
Did I study psychology? Always interest me. I just started taking courses, and because I failed a lot that first year for too much party, and I ended up with a double major with psychology. And I just knew that's what I loved. I didn't want to do OB nursing. I knew I didn't want to do med surge. It just, you'll know when you see it, you'll know. And that's the beauty of clinicals. And some of you might be saying, I do not want to go to clinical. Why do I have to go to a psych unit? But you may end up loving it. It may not be what you expect. But when you get to that place that you're supposed to be, you'll feel it. I did leave a little bit in the 90s and did a couple years of school nursing in an elementary school. But it was interesting. The majority of what I was doing was mental health issues. Eating disorders, abuse at home, depression, anxiety. And the pay was so bad. Loved the job, but the pay was so bad I had to work per diem to make ends meet. So I eventually just went back.
I have a question.
Sure.
So like you said, most nurses or med-surg nurses at least tell you that you need at least a year of med-surg. Why do you think that is a common thought that people need a year of med-surg before they go into psych?
Well, they say you need a year of med surg before you go into anything. And I guess I agree with that. I agree with that with some things like ICU, emergency room, that sort of stuff. But we just do very little med surge and psych. You may not even take a blood pressure the whole time you're in clinical the next 12 weeks. So for mental health, I think it's very different. I do agree with it for other areas, but it's a personal choice, and it's one I made. I've also talked to psych nurses who did that year of med surge, and they felt it was very beneficial. It wasn't for me.
That's so interesting that you say that because I work on a psych unit and all the nurses are like, no, don't do psych. You need to do med surge. And I'm like, I don't know about that. So that's interesting that you mentioned that.
Ask them why. You want the rest to know. I mean, obviously it's personal choice. You kind of learn as you go. But we don't do IVs. We do dressing changes and ports and things like that. But you learn, you kind of learn as you go. The technology changes so fast. In fact, I'm not proud. It's like my father-in-law just had a catheter in, and the home nurse who came here was an ECPI alumni. She was my student, and she taught me how to change the catheter and clean it. And then she goes, "Do you want me to go through this?" And I said, "Absolutely. You need to show me everything." You just learn as you go. So. But yeah, I ask them next time what the rationale is. I don't regret it. All right. Enough about me. Enough of that. This was my doctoral work, and I just want to mention it because you guys are taking research now, and I'd be glad to share this with you down the line. My doctoral work was on humor, the use of humor with the severely mentally ill. And basically, long story short, students and I did a humor group with forensic patients twice a week. And we rated their feelings before the group and after the group to see how humor affected their mood. So I've got lots of stories about that. It was an awesome project that I did, and it's still going today at that facility. It's still being run today. And humor is humor when used appropriately is a very effective coping strategy. To use humor with people to kind of break the ice. So if that's something that interests you, we can talk more about it. And you will see as I teach, I do use humor when I'm teaching as a technique. It does. So there's an example. It does work with patients. Humor. This is my dog Twiggy. And I don't know what my children were doing to him, but the picture's perfect. But you may be feeling like Twiggy right now. You're sending me to a mental health unit, a locked mental health unit with crazy people, and I have to do how many hours there? So is there anybody feeling that way right now? A little scared to go? Nobody, huh? It's a little nervous. Some of you hang out in mental health units, and we're a whole different breed. Where people who feel more comfortable in mental health units than outside are a whole different breed. But it's okay to have anxiety. It's a very different kind of clinical. Okay, so just reinforce what we talked about, and you'll be able to see this when you get your schedule. You will complete 72 hours of clinical within the next 12 weeks. The main site will be South Seminole with Ryan Gabon, who is awesome. He is a retired mental health nurse who worked at South Seminole for about 20 years. He knows the system. He knows the patients. He will teach you an enormous amount of things. So the majority of you have 6 days at South Sem, 10 to 6. Some of you have 5, and then some of you do have 1 day at Right Choice. Right Choice is a daycare center at the end of our street, at the end of Wallace as you're going to school. And some of you had the experience there in public health. So the day program. Caregivers drop their loved ones off so they can go to work. So a couple of you will have one day there. There's not more than one day. It's an interesting place, and it will help you, those of you that are going, it'll help you understand dementias and Alzheimer's and neurological disorders. It will definitely help you a little more. You'll be able to interact with the patients, see the symptoms, see how healthcare providers provide for them, and to see how stressed the family members are. So I tried to give people that one day experience if they had not been there in public health. If I made a mistake and double booked you there, let me know. I think you only need to see it once. You don't need to go more than once. That's right choice. Simulation, again, will be three separate simulations at 2 hours apiece. We will be exploring depression, a patient with depression, a patient with bipolar, and a patient with schizophrenia. Those are our 3 big mental health diagnoses, so we'll be talking about those. And you will get a chance to practice intervening communication techniques with those patients, so you'll get very good at it. An additional assignment for this clinical is for everybody to attend an AA meeting, Alcoholics Anonymous. They are, so at this point in COVID, and anybody can correct me who knows differently, they still do have some online meetings, but more and more of them are returning to their churches or their home base, so they are meeting using COVID guidelines. I make you do this for a couple of reasons. I make you get out of your comfort zone, and if you've never been to AA, you need to see what it's all about, because you're going to be referring patients to AA. And how can you refer somebody to something if you haven't experienced it? Now, if you go to AA, if you are a member of AA, let me know. I'm not, unless you want to, I'm not going to make you use one of your regular meetings as this assignment. You could certainly explore another sort of peer support group, Narcotics Anonymous, or Al-Anon, which is for the family. Or even Overeaters Anonymous. You can take another look at a peer-run group. It's a great experience. You're not to go there and pretend you're an alcoholic. You are there as a student observer. You tell them that right away. Meetings are very open. So they're open and closed meetings. The open meetings are the ones you want to go to. And I'll show you how to find those on their website. But open meetings will welcome anybody. You can go to an AA meeting. You shouldn't, but I mean, people go to AA meetings when they've been drinking with alcohol in their system. All you have to have is the desire to want to stop drinking. So again, you're very upfront about your nursing student, you're doing this hour observation, and the meetings around have been so welcoming. They just love having students there. This is done independently, so you can go tonight if you want. Find a meeting and go to it. You're done. If people find a really good meeting that they found helpful, that they were welcoming, it was a great experience, throw it out there on chat, and then other people can use that meeting also. You can go with another student in the class, but I don't want more than 2 at a meeting, because if we've got 6 students and 8 members of AA, we're kind of starting to overpower them number-wise. So if you're out of your comfort zone and you want to go with somebody, that's fine. You do not have to wear your uniform to this meeting. You can wear jeans. And I do know a couple members of AA who have offered students, if you're extremely anxious about this, that you can go to their home meeting with them, or they'll go with you. They'd be glad to, expose you to AA. There is a brief write-up after you do the meeting, which I'll show you, similar to your logs that we did for public health. And I believe I don't have it in front of me, but I think it's about 10% of your clinical grade. Make the most of it. Learn about AA, hear people's stories. And people should be able to get 100 on that written log experience. So again, that's due. There is a certain day that it's due, but you can do it anytime. You can go to any town. You can go to, if you're flying home to New York today and you want to go to New York, that's fine. AA is all over the country. There is a meeting every day. They say every hour of every day, 24 hours.
I have one question.
Yes.
How are we showing that we went?
Okay, so there will be a validation form that you have somebody sign at AA, similar to what we did in public health. And I'll make sure that's posted. And because AA is anonymous, you don't have to say who you are. Often people will sign friend of Bill or Bill W. And that was the founder of AA. The signature is fine. It doesn't, but they're used to signing those because a lot of people are court mandated to go to meetings. So people who run meetings are very used to signing. And that would be uploaded also with the log, just the date and time and the signature.
Dr. Green.
Yes.
So you're wanting us to physically go in person. We can't do one of the Zoom meetings.
No, I don't care either way. Whatever your comfort level is.
Okay. Thank you.
I would say the in-person ones are probably going to be more personal. But I can't force you to go out in public and.
Yeah, I mean, I have a friend in recovery, so I've been with them before. So I would feel more comfortable if I went to their meeting, but they're in Georgia. They're in Georgia. That's why I'm asking.
Oh, okay. Well, are they still doing it online?
Oh yeah. Well, they actually have COVID right now, so yeah, they're attending their meetings online. But usually they go in person, but not right now, obviously.
Yeah, that would be fine if you know somebody that that they're going to be there. And
okay.
Yeah, again, if you have a friend, a relative, they love. I'm speaking for the world, but I would assume people love to have people come with them to find out what they're struggling with, what AA is all about.
Yeah, they do. They do. They like the like for you to support them.
Yeah. And again, if you've been to a lot of AA meetings, just let me know. We can find something different if you want. But I can't, students, they roll their eyes when they get this assignment, but I can't think of one student that hated this experience. It was very eye-opening. The only suggestion I would have is if you live in a small town or small community, go outside that community to do your meeting. It can be uncomfortable in small towns. You run into your neighbor, you run into the soccer coach, sometimes that can be uncomfortable. So that's the only suggestion I would have, though. A lot of noon meetings. There's one in Lake Mary at one of the churches that's at 12 o'clock. That's a lot of professionals. They come on their lunch hour. That's always been a really good one. And if it says closed, if you go to the website and if it says closed, that's not a meeting for us. That's only for people who are members of AA dealing with alcohol. So that those are closed meetings. There are meetings for women only. There are meetings for teens. There are meetings for nurses who are trying to maintain sobriety. There are meetings for medical professionals. So if you go to Google AA, you can pull up the website, put in your zip code, and it'll tell you everything that's going on around you. And it has been listing virtual, remote and in person. Any other questions about that or?
Aren't there also smoking and non-smoking meetings? Is that still a thing?
I'm sure there are.
I've heard of that too.
There's even, there's a lot of variation, but for a while there were meetings for people that had a mental disorder on top of it. So we call it double trouble. So if someone has a mental or dual diagnosis, someone has a mental health issue and an addiction, those are a little more specialized. Because often they'll say no medicine, you should have no medicine in your system. But if you have depression or you have schizophrenia, you need that mental health medicine. So a lot of people were finding that they were discouraged from taking their regular meds. So that with a dual diagnosis sort focus meeting, that was a better fit for a lot of people. Any other questions? Okay, then I'll show you the log and enjoy it. It'll be great. I'm correcting those. There'll be a place on Canvas. You can upload it whenever you're done. Okay, and then pick project. Everybody is doing 4 hours. When you get your schedule later today, you can take a look at it. And we will be focusing more on mental health issues and some mental health teaching. But we have not been there for a couple weeks and they've been asking for us. So I'm sure we're going to be giving out a lot of Tylenol and stuff when we go back. All right, so those are our clinical hours between your hospital hours, AA, SIM, the EPIC training, it comes to 72. I'm not going to keep track of it the way we did for public health. You have to carry your timesheet. There will be, this is just life. There will be days you might get out early. There might be days you have to stay a little later to finish something. But everybody's hours will equal out till about 7. If you are ill on any of your clinical days, you do need to do a makeup and it has to be done during week 12. So again, I don't want you coming sick. There's nothing like the flu going through a mental health unit because people are just stuck there. But please, if you can get there and get your hours done, get them done. Okay.
Could we do like an extra picnic project or something, or no?
For instead of what?
Oh no, I was just saying like if we were sick, and we just had like some extra hours or something, could we do an extra one like public health?
We may be able to negotiate that. I can't promise though.
Oh no, that's okay. I just didn't know if that was an option, but no worries.
Yeah, it's a little tighter than public health was. We were kind of all over the place, but if it's possible, we could get that done.
Okay.
But we try to make it week 12 so that people are, everybody's not calling off right before a test or whatever. So we'll try to be there. And there's no switching. There's no switching of your assigned clinical days except for project. And Ms. Vogel's usually pretty flexible about SIM if something's overlapping. But the hospital ones are pretty set. So what you're assigned, kind of get it in your schedule, and we're really going to try to stick to it. Okay, anything else about clinical?
I don't know if you already said it, but do you know what time the clinical orientation is tomorrow?
Yeah, so it's just going to be us. I haven't decided. It's just us. 11 o'clock. I'm deciding right now. How about 11 o'clock? 11 to 2 tomorrow? Go ahead.
Can we do it a little bit earlier than that?
Oh, you're killing me. Who is that?
10.
Who is
Mira.
that? Who is that?
Mira, I'm only asking Because I have like an emergency doctor appointment that I have to go to tomorrow, and the latest I was able to schedule it was at like 2:30. So I don't know like how long it's gonna take.
What time would you have to leave, Mira?
2, because it's not far away.
Okay, so how about we do 10 to 2? Does that work for everybody?
Yes.
Any
Yes.
objections to 10 a.m. to 2 p.m. tomorrow? And then Mira, if you've got to step out, you can just go back and look at the video or a lot of tomorrow.
Thank you.
Yeah, it's going to be weird. I mean, we're talking about clinical now, so a lot of tomorrow is probably going to end up being lecture that we don't get to today. That's because we're losing a class next week. So, okay, we'll do 10 to 2 tomorrow. And that'll be on the same channel we're on now. All right, so this is very important. This is the best part of every week in clinical, we have in mental health. Can you guys see me? Can you see my picture?
Yes.
One last
Yes.
thing on
You're
the
small.
schedule.
Yes.
You're small.
What's
at the
that?
bottom.
Professor,
Yes, Dave, what?
Dr. Green, on the 2nd of April, there are clinical assignments that we have for OBPs, and you have the case study presentations that day on April 2nd. There's a Friday day clinical, all day, 0600 to 1800 on April 2nd.
Okay. Well, and I've got something scheduled for that day.
Case study presentations.
Oh, okay. Hang
Is
on a
that
second.
what you said?
So yeah, they're not due that today. So case studies, this is an assignment for class that Steve's talking about, that we will talk about. It's a case study of a patient that you meet in clinical, and you guys will be presenting every week up until the week of March 30th. So I just stuck that date in there,
Okay.
Steve, as
All right, I'm sorry.
that's the last day people can no, it's confusing. That's the last day people can upload stuff. But it is a group project for class 439. You will be signing up for that today also. And you'll be assigned a week to present. No, I'm glad you point those dates out. Sometimes I stuff in there and they don't really make sense. And I'm sure you guys have noticed the Canvas looks a little different this time. Just the layout of everything, the syllabus and everything's a little different. So it's gonna take us a while to get used to that layout. All right, so this is a trophy that is given out once a week to the mental health nurse of the week. And this is chosen by, it'll be Ryan and I. And this will be awarded every week during class, and you actually get a physical trophy. So we will have at least 11 nurse, and you get to carry the title of mental health nurse of the week for that whole week, and it's an honor. So, okay, clinical expectations. The uniform for mental health is the khakis and the purple polo. Again, if you don't have them, you can get a polo from Mr. Fontaine. Make sure your khakis aren't too tight. If you really don't have that uniform or it's dirty, or you can wear your scrubs. We just try not to wear scrubs in mental health because it very much makes it us against them. So, when you dress a little more casually, it brings that stigma off the mental illness, and you're the patient and I'm the nurse. It brings us a little together. Plus, I think it's a little more comfortable. So khaki and polo for all sites. Worst case scenario, you can wear your scrub uniform if you need to. Sneakers are fine as long as they're clean. They don't have, you know, words on them or anything like that. But they are fine. You may be playing volleyball. You may be exercising with the patient, so it's okay to be comfortable. The
Could we do
hospital
like,
sometimes is, go ahead.
could we do like the black scrub pants with the polo shirts?
If you really don't have khakis, I would say yes. It's nicer when everybody matches because the patients can look at who you guys are, you know.
Okay.
If you really don't have khakis, you can. And khaki scrub pants are fine. It doesn't have to be like khaki. If you want to wear khaki tan scrub pants, that's fine too. Anything else about the uniform? It does get a little chilly at some of the sites. You can wear Under Armour or a white undershirt under the purple. Tattoo should be covered. You can bring, this is tricky in mental health, so you can bring something to keep you warm, but units don't allow anything with a hood or a belt, like, or a sweater with a belt. That is for safety. So nothing with a hood or a belt, which eliminates a lot of what we have. So if you have something like a pull-up jacket, like a pull-up jacket, it would be worth bringing it in case you get cold. You should bring only what you need to the clinical experience. So whatever, Ryan will go over this with you, but try to only bring minimal things. You shouldn't be bringing large amounts of money. Something to write on and a pen, your textbook if you want it. But that's, and food, but that's pretty much all you need. There is a place to put our things, but it doesn't mean it's secure. I don't want stuff disappearing. And anything brought into a mental health unit can be looked at. Your bag or your purse can be checked by security, and we don't want to be bringing in anything that's contraband or shouldn't be brought in, like glass or scissors or metal or anything like that. Medication wise, personal things if you need them. Obviously bring them clinical, but keep them pretty secured. We don't want Tylenol falling out of your pocket, or make sure it's in a safe place, inhaler or whatever it happens to be. Questions about that? Okay, there's a lot of rules, and we'll talk about it, but there's a lot of rules in the mental health unit. You can't notebooks with the metal rings in it, glass, metal, aluminum foil. Some places don't allow gum. A lot of things that people can hurt themselves with, or barrier a door, or deactivate a lock or something like that. So they're pretty strict.
I have a question.
Sure.
Are we not allowed to wear belts onto the unit then?
You can wear a belt, just don't take it off. Belt off. Yeah, they can't have belts. You certainly can if you're a belt person. We're just not. I'm talking more like the girl sweaters that have a belt around them that they disconnect. Something like that they wouldn't allow you to have. It's a safety issue. If somebody got a hold of it, they could strangle themselves, strangle you. That's a good question. The hoods are for a couple of reasons. One is somebody, you have a hoodie on, somebody grabs you, they've got you. They physically got you. But the other thing is people who want to tune other people out can just put that hood up, and then the nurses can't see the patient's face. So the general rule is kind of no hoods so that people don't hide. Hats too. They don't do hats because you could hide something under them. So it's the same sort of thing. Anything else about uniform? What to bring? Yeah, I'm sorry.
Is there going to be the same rules where we can't leave the location for lunch, so we have to bring our lunch with us?
So there's a cafeteria. There's also a place you can bring a lunch and cook it.
Okay, thank you.
Ryan, just so you know, Ryan usually does a working lunch so that you're out in 7 hours instead of 8. That's definitely something you can negotiate with him, but that's what he's always done in the past. So everybody kind of eats together. You guys eat together and do some talking or presentations during lunchtime. So yeah, you can buy, I don't know how the food is there. You can buy, or you definitely can bring. There's refrigerators and stuff. Stay away from metal cans, cans of soda. But you could definitely have silverware, whatever you need, just whatever you take on the unit, make sure you're taking it back off. Okay, so cell phones, we can't have cell phones in the patient areas because of confidentiality, as you can imagine. But we know people need their cell phones. Ryan will tell you where cell phones need to stay. I don't know what he does, to tell you the honest truth. It may be in your car, or he may lock them in a locker in the break room. If you've got something going on personally where you need access to your cell phone, let him know that. I mean, we're not that cruel. We will let you check your cell phone. If it's a child issue or somebody needs to get a hold of you, Ryan will even say, give him my number, because he has his phone on him. You could call right to Ryan's number. That person could call right to Ryan's number and get or I believe I posted the number for the unit, so you could also call the hospital. Someone could call the hospital directly. But cell phones are a big no-no. And I don't know how compliant staff is with that, but we have to be real careful not to be on our cell phones. You got someone who's paranoid, and if you're looking at your phone, they think you're talking about them or taking their picture or whatever. Be on time. If you are more than 10 minutes late for clinical, we have to send you home, and it's an absence. So just make sure you give yourself enough time to get there. Bring respect, respect the patients, and be non-judgmental. Kind of come with an open mind. Ryan and I do not expect you to be perfect. We don't expect you to be therapists when you're done with this class, but you will learn a lot. And if you be respectful and look at people as people and not judgmental, we appreciate that. So now, be careful about, not that anybody would, but be careful about getting in groups of students and talking or whispering, because sometimes patients will misinterpret that as you're talking about them, or you're whispering about them or something like that. So just be really respectful. People are people. Our patients are people. It's a very fine line who's in the mental health unit today and who's going to be the nurse on the mental health unit today. So you might have a nurse as a patient. You may have a doctor as a patient. Mental illness hits everybody. They will say more about that later. But those are our expectations. Just try hard, use the most of your time. Be assertive if you see a group going on, or if you see a family meeting going on, ask if you can be part of it. The worst they can say is no. There are some nurse practitioners who work in the ED there. the Psyche D that Ryan can hook some people up with if that's something you're thinking about for future careers. But make the most of your time. And I tell students this, these 6 days you have, so 48 hours is it's going to be the only time in your career that you're just going to have talk to patients and practice therapeutic communication and learn about mental illness. The rest of the time in your life, you're going to be doing dressing changes and hanging IVs, and you're going to have to do a suicide assessment at the same time. This is the time that you don't have all that extra stuff. Just sit and talk with patients and learn as much as you can. All right. We'll do this slide and then we'll take a break. So what will you be doing? So a lot of you might be thinking, what am I going to do? It is very different from med-surg clinical. Again, you may not do a blood pressure the whole time during this rotation. You will be working with patients that Ryan usually lets you pick out kind of who you are drawn to. Kind of meet everybody in the milieu or the therapeutic area and then kind of see who you're drawn to. You can go to groups with them. You can go to family meetings with them. You'll be able to hear a report being given to the staff. You may be able to sit in with the doctor while they're doing a therapy session. But a lot of the time is going to be you and your patient just sitting within that living room area and getting to know, I want to say getting to know each other, but it's more about getting to know the patient. Them talking about their life, their mental illness, how they got into the hospital. What can you do for them? Listen, ask them questions so you can understand what their life is like, that empathy. Teaching, you're going to be talking medication with them. You're going to be doing some teaching about depression or whatever their illness is. Really getting to know the person. So we're going to talk about Hildegard Peplau. She's a theorist, and she believes that using yourself as a tool is the most therapeutic thing you can do for a client. So offering yourself, using yourself as a therapeutic tool, letting people know you care, listening, giving them maybe some options or helping them do a pros and cons list. So you won't be talking for 8 hours straight, but you're definitely going to be using yourself as a tool, a therapeutic tool with your patients. This clinical is very eye-opening for a lot of people. You may look at yourself as far as emotional issues. It might be some things you see that are very close to home. It may remind you of someone in your life who's struggling with some mental health issues. So a lot of feelings come up during the mental health rotation, personally. So we do spend a lot of time in post-conference just talking about what you saw during the day. Did it remind you of somebody? Did you feel bad for this person? How did you handle your communication? So we do a lot of analyzing in how the day went. We don't want you to hear terrible stories and see people cry and then send you right out home. We want to give some time to kind of decompress that, because it's tough when you're working with emotion. And it's interesting, you'll go home on that first day and you're exhausted. And it's not because you've been running around for 8 hours straight, but just listening to people's stories and getting to know people and doing something that's different can be physically exhausting. So it's a different kind of nursing, different kind of tired. And again, you may not ever want to be a psych nurse, but no matter what kind of nurse you're going to be dealing with people with mental health issues. So use this time the best of your ability to learn about these issues, how we can help people. Again, you may be playing games. Yes, it's okay to play games with people. It's a great way to connect. You'll all be on the children's unit for at least a day. So you'll be seeing how children with mental health issues have to kind of juggle school. They have school right there. And playing games with them is a great way to connect with them also. What kind of questions do you have?
You answered my question. I was gonna ask what like the age ranges were. So you said one day we'll be at we'll like be on the P4.
Yep, everybody will have a chance to rotate through PEDS. So child and adolescent is up to 18. The youngest I have ever seen at Halifax, we had a 3-year-old. We had a 3-year-old one night. And you probably wonder, what does a 3-year-old do? Violence, attacking parents, a lot of aggression, autism. When they get to be 16 to 18, they can either go to an adolescent unit or they can go to an adult unit, depending, they kind of look at how mature the person is. So yes, you'll all rotate through child and adolescent. There's a chemical dependency floor where we've got that. There's that dual diagnosis. There's a mental health issue and chemical dependency. There's an acute unit where people are sicker, so they would come to that unit on admission. And then there's a quieter unit where they're getting ready for, I shouldn't say quieter, it's more stable. They're getting ready for discharge. So everyone in Psych ED, admission Psych ED is another area. So everyone should have a, have an opportunity to rotate through. If you're nervous, tell Ryan, I'm not ready for the acute unit today. There's always somebody in the group who's ready to jump in there. I've got kids, I'm not sure I can handle the kids unit. Talk to him about that. You can work around. There's a lot of elderly with dementias and Alzheimer's, but you'll see every mental health diagnosis we talk about. The majority of the people are Baker Acts, so they're brought in against their will.
That's the acute unit, probably.
Actually, all the units.
Oh.
Some people sign themselves in, but a lot of it is Baker Act. Children are Baker Acted too. But what happens, hopefully, is people settle in. They want to stay there and get some help. So often they go from being a Baker Act to a voluntary patient. Units are locked. So yeah, you could see from 5 years old up to 100 during this rotation, 100 years old.
Will we be doing
Anything else?
any med administration?
We will not. It's too hard to get it done. You're going to be able to observe the med nurse, and you need to know your meds. You're going to be memorizing those medications, and I expect medication teaching. But no, we won't be giving.
We don't need to bring our stethoscopes, do we?
No.
Okay.
Isn't that funny to hear? No, you do not. If they need a blood pressure, they've got the machines and stuff there. As little as possible. Bring as little as possible with you. All right, why don't we take a break? Let's come back 2:30, and we'll start talking about the class a little bit. Okay.
Professor, I have a quick question.
Sure.
So for picnic project, I'm scheduled for March 7th, and that's the day, right after I come off of a 6 p.m. to 6 a.m. shift at Arnold. Is that normal for students, or was that a mistake?
So you got to go in 6 p.m. Saturday?
Yeah,
or 6 p.m. Friday?
I go in 6 p.m. to 6 a.m. on Saturday, and then that Sunday I'm scheduled for picnic project.
Yeah, that's a mistake.
Okay.
We've had Friday night overnights, but we haven't had Saturday. So if that happens to anybody, tell me, and then tell me another day, and we'll get you switched up. Tell me
Okay.
another day that works for you. Yeah, I don't want you to do that. That's great.
Oh, okay. I'll just send you an email then.
Yeah, I hope, how many overnights are there from, is it just one group, Saturday to Sunday?
No, it's like, I think I have like 6 overnights. And they're mostly on Saturdays.
Oh, wow. Okay.
Yeah, I think I have 7 in their Saturday.
Okay. Yeah, so if that happens, yeah, I don't want you coming, I don't want you getting home at 6 and having to be picked project for 11:30. No. So just tell me that your conflict in an email. Give me another date you're free, or even worst case scenario, picnic project always needs help on Tuesdays, I'm sorry, on Thursdays and Fridays in the afternoon. Thank you for pointing that out. Now I don't want that to happen. We'll work it out. And yes, you're coming on Valentine's Day, Melissa. I know it's Valentine's Day.
Are you bringing me some chocolate?
No, but you can bring me some.
Oh, okay. I didn't get my Christmas. Merry Christmas.
Oh shoot, you're right. I didn't. All right,
Yep.
I'll bring you chocolate.
And Emily even rubbed it in. She goes, "Did you get a Merry Christmas?" I'm like, "Nope, no, I didn't."
All right, I'll bring chocolate for Valentine's Day.
Yeah, you're terrible. I'm just joking. I'm just joking. But we got a good group on Valentine's Day. Woo! Andrew, I expect roses for all the ladies.
It's the group from the other side of Florida.
Yeah, pretty much.
Yeah. I just realized though, I'm actually in the same pickle that the day before, that morning I get off at 6 a.m. I'm doing it overnight, but I might just suck it up because I don't know.
I don't want you driving like that though. I don't want.
I haven't even looked yet, so I might be in the same pickle. I'm not sure.
Your schedule and see if there's another day that works better. I really don't want you out on the road on I-4 when you've slept 2 hours. I mean, Melissa, we could always do that Friday, passing out groceries or something, the Friday before if you're free or whatever. We can work around it. We're not that married to it. We'll get there.
Okay, because I know Andrew and I are in the same group, so we have pretty much the same clinical schedule. But Grace is, I think like because she went to Advent before, like she's at more Advent hospitals than Orlando Health hospitals. I'm kind of jealous because I've never been to an Advent hospital. So, and I didn't get any, but that's not you. But so if we have an overnight, it'll be Andrew and I probably.
Talk about we'll work it out.
Yeah, same thing with me. I have an overnight. We'll see. We'll see.
Okay.
Oh, Melissa, I'm looking at it. Yeah, you guys have that overnight with me too. We're all on it at Winnie Palmer on the 13th.
So are you guys free? You guys if you had an overnight on Saturday, what do you do on Friday of that week?
We have a sim lab from 1:15 to 3:15.
Okay.
For OB sim lab.
All right, so we maybe should just email me. You guys email me individually and tell me what day you'd like to be assigned if you have that overnight. Yeah.
To change the picnic project date or to
Picnic project. Yeah, no, we'll change the picnic project date.
Okay.
There's got to be a
And you
day
said
that you have.
Fridays too?
There we can always go on Fridays at noon and Thursdays at 10. They're always looking for help making bags up of food and stuff. Fridays they pass out food just like they do on Sunday. So we could even set up a table.
Okay, the 4 of us will get together and talk, and then get back to Valentine's Day.
Problem solved. I really don't. The dean will have my head if I've got you driving on I-4 and you haven't slept all night. There's a couple weeks that we're not assigned. I mean, we can even look those weeks that we're off, so.
Yeah, you didn't assign February 21st just for an off day.
I didn't because it's my birthday.
Oh, look at you.
But if that works for you guys, I'd be willing to go on that day.
No, it's your birthday.
Oh, what am I doing? You come up with a solution, let me know. I don't care.
I mean, I
Okay.
think we're free those Fridays, that 19th and the 26th. Or even the following, yeah, those Fridays. We'll see.
Okay.
We'll let you know, I
If
guess.
you guys, I know if you carpool, so if you want to stay together, just let. I was almost worried about this Sunday with the playoff games, but I kind of panicked about that. All right, let's take a break. See you at 2:30.
Okay. Bye.
Reset that bitch.
Okay, guys, it was a short break, but we're back. I want to just wrap up talking about clinical so we don't start getting confused. So you guys should be able to see, I'm hoping, a page that says assignments 436.
Yeah.
Yes, no, maybe. Okay.
Yeah, we can see it.
Okay, so let's just wrap up what we were talking about so we don't get confused. So 436 is clinical, and this is how you're going to be graded in clinical for mental health, and it is laid out under assignments. So each clinical day that you are with Brian or Right Choice, you're going to get 5 points per day for participation in pre and post conference. There's nothing you have to write. There's nothing you have to turn in. You just need to be engaged, interested, and participate, and you will get those 5 points per day. And that's 40% of your grade. There is a mental health project that you will be presenting within clinical post-conference. I could talk about that in a second. It's an individual project. It's meant to be fun, and it's meant to be educational. It's 20% of your grade. Brian will be correcting those. And you would present, I'm talking a less than 5-minute presentation, and I'll show you some examples to your post-conference group. So one of the options, I have a whole rubric for this, but one of the options that a lot of students choose is to choose a movie of their choice that has a mental health issue or concept in it, which is most movies. And the student would pick out, so let me give you an example. A lot of people would some people might pick A Beautiful Mind, which is a wonderful movie about schizophrenia, a very positive movie, true story. They would watch A Beautiful Mind. They would take the main character, who is Dr. Nash, and they would go through the rubric, which is going to ask questions. What diagnosis does your main character have? What are the signs and symptoms of this diagnosis? How is it treated? And then the part of the presentation was this movie realistic? Did you enjoy it? It can be a movie, it can be a documentary. And again, I'm not talking a half an hour PowerPoint presentation. Just briefly present it to your peer group. This movie talked about PTSD. It was very realistic. These are the signs and symptoms. These are the meds we use for PTSD. So again, what a great way to kind of learn and have some fun. Ryan actually he brings his computer and stuff. So with a thumb drive, if you brought a thumb drive or emailed your project to him, he could bring it up. He brings it up on the wall right there at South Sem. So that would be arranged with him. So if your clinical days are the next 6 weeks, when you meet him next week, that would be one of your goals, is to say, Ryan, I would like to do my mental health project. I'd like to present it on week 4. That's a possibility, and get you scheduled. Okay, so when I go to modules, I'll show you the rubric, but have fun with it. There's no reason you can't get 100%, so 20% of your grade. It's just a fun way to share information. If you like movies that you find interesting, it can be a book, it can actually be a song, it could be a poem. There's so much out there about mental health and mental health issues. Okay, let me keep going, and then when I get to the rubric, you can ask questions. And I'll definitely show you a couple examples. Okay, so there are 3 clinical logs that are a part of the mental health clinical. I gave them due dates, and everyone's going to be going to South Sem kind of at different times. So I would like you to do the clinical log on one clinical day that you had, depending on where you were, answer the questions. If it falls that you don't have a clinical day for some reason by February 12th, that's probably not going to happen, but if it does, let me know. I haven't done the actual log write-up yet. I'll do that tomorrow, but it'll be very similar to what we did in public health. Probably with more of a focus on what you saw. Was there anything that you didn't like, that you thought was really great intervention, the way people were treated? It's going to be a little bit more of a self-exploration. I will be correcting those. So everybody would turn in one on February 12th by midnight. Some of you will have done South Sem, some will have done Right Choice. If you didn't have anything else, you could do picnic projects. It should be mostly hospital, like exploration though. Okay, so there's 3 of those. Try to spread those out. So the 12th of February, the 12th of March, and then April 2nd. And upload them similar to what we did in public health, just like a 1-page document. You will have a midterm evaluation. You will have a midterm evaluation with Ryan halfway through, whatever your halfway through mark is, and he's very good at keeping track of that. And then you'll have a final evaluation with him also. Okay. So this, you can see there's no big nursing care plan here. This is kind of your nursing care plan, this mental health project. You're going through the criteria of a person who's undergoing mental health issues, and you're giving nursing process, but in a different sort of way. Questions on those due dates?
With the mental health project, is that what you meant by that binge list could be helpful in an assignment?
So the binge list I posted, if you saw it, I posted it yesterday. That's kind of some of my favorite stuff that's out there. Any of that stuff on there could be used for the mental health project. It could be a podcast you're listening to. I've even had some students write their own. You wouldn't necessarily, you'd want to share that, but I've had some students write their own experience with mental health issues, like the self-exploration. Yeah, we're kind of open to anything. Yeah, those are shows I've kind of just accumulated that are really good as far as mental health issues. If you don't know what to watch. Ratchet was really, I don't know if you guys watched it. That was a series that just came out. A lot of good history that was very accurate about mental health treatment. And then that was done, that's on Netflix. It was done by the people that did American Horror Story. So it was pretty good. Okay, let's jump. I'm going to jump to modules in 436 just to show you it's a little different. Are you guys seeing the screens changing?
Yes, ma'am.
Okay, good. So you can see the syllabus is looking a little different than you've seen in the past. There's a lot of changes going on, but your assignments are there at the percentage of each. It just seems like the easiest place to look is under assignments and dates and stuff. So the other thing I try to do, if things are going well as far as time, every week that we have a theme, I try to post some. I try to post some scales or tools. So I'm sorry, I'm going all over the place here. So for what, say chapter 13, if we talk about suicide, how to do a suicide assessment, then I would post what's called a sad person scale. You'd be able to click on that and access it. It's something you could use for studying purposes, or you could actually use this on a patient in the hospital. And they're tested scales and criteria that we use. We have some on anxiety. We have some on PTSD. It's something that's done usually with a patient. You come out with a score, and you can kind of see how severe their symptoms is. So I'll try to, each week that we go through different diagnoses, I'll try to post the scale that's connected to that. There's even some about human trafficking, like what kind of questions you could ask somebody human trafficking, or a victim of that. Okay, so that's 436. I'm going to pop over to the class. Anything about clinical you want to ask about?
For the Alcoholic Anonymous log, where can we find the rubric for that one?
Yes, I will be posting that for you. It's not there yet, but I promise I'll get it up there. And the sheet for people to sign, or whoever to sign. Okay, yeah, if you don't see something, just remind me. We did a lot of moving. Huh?
Sorry, are we having our clinical orientation tomorrow?
It's mostly going to be, we are going to meet from 10 to 2, but it's mostly going to be lecture because we're talking about clinical right now. Does that make sense?
Yes, thank you.
Okay. I'm trying not to jump around too much, but. Okay, so just to wrap up clinical, here's the rubric for the mental health project. Choose a character from a movie, television show that portrays a mental illness. Analyze how that movie or television show depicts the character suffering from the mental illness. So there's points for creativity, your PowerPoints, which end up being, you can either do a poster or you could do about 10 slides, PowerPoint slides. What's the plot of the movie? What is the character suffering from? And then you're going to tell me facts about that mental illness statistics. 25% of people in the United States suffer from depression, or whatever you can find out there. List 5 signs and symptoms of that mental illness. 3 ways that that mental illness is treated, including medication. What causes the mental illness? And we may not know. A lot of mental illnesses, we don't know what causes them. So you could just say that. Or it could be the person suffering from PTSD. He's a war veteran. You can just describe what's been happening to that character. And then the conclusion would be, did the movie accurately portray the mental illness? Or why not? Like movie Why or Why. The majority of movies about mental illness are not very realistic. Beautiful Mind happens to be one that's pretty factual, and it's uplifting, not a downer. It can be, and it could be any kind of movie. I love the movies with the asylums where the nurse is chasing some asylum. I mean, you could do a movie like that. But know that a movie makes a good movie movie makes a great movie, but it's not necessarily true. So Split, Split is very accurate. The way he portrayed multiple personality disorder was very accurate, except they don't climb on the walls backwards and that kind of stuff. So just to kind of sort out what was real. Did this movie contribute to more stigma about mental illness or people not wanting to go for help? That sort of. So again, that's done, and I'm going to move this. That's going to be done in clinical to your peer group on a day that you choose with Brian. And you guys can do the same things. It's that's okay. You can choose the same movie once you have your own project. Okay, so I'm jumping over to class now. Class is 439. Are you able to see the assignment page?
Yep.
Okay, thank you. All right, class-wise, you have a ATI for this class, which is 10% of your grade. The mental health ATI is not easy. It's a tough one. So you guys are getting to be ATI, but my suggestion to you is to get that ATI book right out this week. When we do chapter 1 in a couple minutes, what is mental illness? Go through your textbook, look at the PowerPoints, but also pull out the part of the ATI book that talks about that and just start reinforcing that information. It's I'm trying to remember, it's a little bigger. The ATI book's a little bigger than your public health one was, so jump on it. Don't wait till the last week to crack it. So the ATI is 10% of your grade. Remediation would be done the same way we've done in the past, where there will be a practice that opens. You do the remediation on that practice, and then you come and take the proctored. Do the remediation on the proctored. Okay. The textbook, ATI doesn't have textbooks, which makes no sense. The textbook's pretty consistent with ATI. There's a couple things, couple interventions that ATI really likes to focus on in the mental health ATI, and I'll point those out as we go along. One is electrical stimulation treatment that they use for people with depression, or sometimes ATI gets hooked on just a couple meds that they really want you to know. So as we go in lecture, I'll point that stuff out. But again, don't wait to the last minute on that one.
Dr.
And
Green,
then, yeah.
sorry, do you know when our textbook will be available? Because I don't see it on the bookshelf yet.
You guys haven't got it yet?
No.
Nope, but let me text Jody right now and ask her. I meant to ask you. Yeah, I meant to ask you if you guys had access yet.
Yeah, that's the only one we don't have access to yet.
Ours.
Yeah.
That figures. Okay. She'll get right back to me. It's actually a good book. It's easy reading. You'll find it much easier than public health textbook. There's a lot of graphics. There's a lot of charts, cartoony things that kind of get your attention. The only thing I don't like about the book, I have one complaint, and that's the author puts in chapter 2 all the medications of mental illnesses and all the biological causes of mental illnesses. Excuse me. So chapter 2 is a little overwhelming. It's just a lot. It's a lot of information. It can be kind of dry if you don't like pharmacology in the brain and all that jazz. We're going to tackle chapter 2 tomorrow. We'll start that right when we get together at 10 o'clock tomorrow when you're fresh. But chapter 2 it's just a warning. Chapter 2 is one I would read a couple times, spend spend time on chapter 2. So it'll go through all the different kinds of medicines, and then when we get to the chapter on depression, it'll review antidepressants. We're gonna go back to it. She kind of piles it all on. Chapter 2 is in those meds. The only way you can learn it is to memorize it. I can talk for 6 hours about psychotropic, what we call psychotropic medication, but if you don't memorize it, you're not going to get it. So just a suggestion, get those meds down. I am a proponent of reading. I really don't think people can be successful without reading the book. So I think you should read at least the chapter at least once, and hopefully before the lecture so you can ask questions. All right. Second assignment, case study presentations. You guys will be breaking into groups of probably 4 to 6 students, and I will let you choose your own group. You are going to take a patient that you meet in clinical. Or the other possibility is some groups have taken like a famous person and worked them up psychiatrically in a nursing care plan. And I will post an example of one for you, and I'll go through one. But when your group is assigned throughout the semester, I will lecture. So I'll lecture on anxiety, and then your group topic is anxiety. So say you chose Britney Spears. So say you take Britney Spears. I don't even know if she's been diagnosed with anxiety. And you're going to tell us all about Britney Spears, her case study, her symptoms. You're going to learn how to use the DSM, which is our rating criteria for mental illnesses. You're going to do nursing process. You're going to do interventions, goals, interventions, evaluation on Britney Spears, or a patient that you meet in clinic. It can be either one. So, I mean, technically, if you want to use, and you don't have to make all these decisions today, but if you wanted to use a patient from clinical, you probably should try to pick a case study group that is going to be together at clinical so that you're all there on the same day to meet that person and get all that information. So it could be a real person. It can be a celebrity. People have done some interesting people. I'm really kind of open to anything. You want to do a historical figure, work them up in nursing process. It's group work. Everybody needs to contribute. Everybody gets the same grade. But again, it's if you sit and listen and take in the information, it is going to reinforce, those presentations will reinforce everything that I just lectured on. So again, it'll coordinate, the topic will coordinate with whatever the lecture is that week. So once you choose your groups, you can let me know by email, and I will assign the diagnosis and the date that you present, but it's just going to be random. And I'll go through one of these with you probably tomorrow, just to show you what they look like. Any questions about them? Again, you don't have a written care plan, but this is the time as a group that you can come up with a nursing care plan for a client with mental health. And again, it could be a child, it could be an older person, depending on what your diagnosis is assigned to you.
And this is for the case study presentation, correct?
Correct. Yes.
And how many people can we have in this group project?
4 to 6. So no more than 6. Or
Okay.
if somebody really wants to work alone, I don't have a problem with that either. Up to 6. I should say.
Okay, are we allowed to have 3 people, or does it have to be a minimum of 4?
Yeah, we'll say up to 6. No more than 6 in the group.
Okay, thank you.
And again, if you want to use a patient from South Sem or from Right Choice, you might want to make sure that you want to make sure you guys are all together on those clinical days so you can work together on it. Okay, so that is 10% of your grade. And those will all be done by the week of April 2nd. But we'll probably start those in a couple weeks. So the first group will probably present in 2 weeks. And the first group always gets a little leeway. It's hard to be free. You have 3 exams for this class. They're worth 20% apiece. They are spread out and they are on days that you do not have research exams. So Dr. Wheeling and I made sure that you're not overlapping as far as 2 exams in a day. Exam 1 will be February 3rd. Again, it'll start at 1 p.m. At this point, they're remote. Exam 2 will be February 24th. And exam 3 will be March 17th. Chapters on those exams, I can post those for you. It will be, I'm not going to test you on anything we don't get to, so it'll pretty much, exam will be everything we do from today up until February 3rd.
Excuse me, will there be another syllabus that kind of says everything just so I could like plan for the future?
No, there's no syllabus like that anymore. That's why it's so different.
Okay.
It is very different, isn't it? Like as I said, I found that the easiest way to look at the assignments is go to the assignments tab, whereas before we looked at the syllabus. Go ahead. I'm sorry, I interrupted somebody.
I was just saying, like, it's literally just the things under assignments. So 1, 2, 3, 4, 5, 6 things.
Say it again. I'm not sure what you're saying.
I said under assignments, there's just 6 things. There's the proctored assessment, case study presentation, comprehensive final, exam 1, 2, and 3. Yeah. But then we have other stuff due on the clinical.
Yeah.
Okay.
Right. So you got to keep an eye on both those classes. You got 2 separate classes. Yeah, you need a big calendar to block this stuff out. Exam 1, 2, and 3, and then there is a comprehensive final on April 6th, and that'll be the same day as the ATI. That one is worth 20%. My exams are not easy. You definitely have to read and you have to study. It's not fill in the blank. It's not, this is a definition of depression. A lot of my questions, you have to take the information you know and apply it to a situation. So for example, your client is exhibiting this. What kind of intervention would you plan for them? Some students have found note cards are helpful. I've had students post, paper on the wall and just write depression. These are the signs and symptoms. These are the meds to separate things out. But I'd encourage you to stay on top of your reading. Really stay on top of it. And if you don't understand depression or schizophrenia, let's work on it. I mean, I can do tutoring hours. We can go over it and over it till you get it. Okay. Yeah, you definitely need a big calendar to post all this stuff in for sure. Yeah, I don't really like this new layout. I was part of developing it, and I'm not I'm not pleased with it. They're doing this, they're doing it like all through ECPI all over the country so that like anybody could pull this course up. This course would be the exact same in Orlando as it would be in Virginia.
I'm not trying to make more work for you, but like Wheeling posted her own course outline. Like there's the syllabus on the website, and then she posted another one that she usually does. But I mean, as long as everything's due under the assignments, then that's easy enough. We can just go by that.
Let me see what I can do. I might even make more sense for me to make a calendar. To make some sort of calendar so you could. Let me take a look at it.
Many of the things that you indicated that are assigned are already on a calendar. It automatically transfers over to our calendar.
Oh, it does. Okay.
So you may
Alright.
want to check it and see what loaded and what didn't, because I noticed for our last class, some things didn't load. And I don't know what causes things to load or not load, but that's what I use as my template for my schedule.
Okay. All right. And then we have this lesson plan that's set. I mean, this is kind of what you're talking about with the syllabus. It'll tell you like each week what we're supposed to be going through. But again, if we don't get to something, I'm not going to push through it too fast. So I don't know. I'm feeling frustrated. Are you guys feeling frustrated?
A little.
I think we're going to have to use coping strategies.
Oh. On
What was that?
On the case study presentation, I'm excited
Okay.
about it. On the
Oh.
case, on the case study presentation, you're going to give us the disorder. Is that what I understand? And then
Yeah,
we
so
find
Steve,
something, a patient that's compatible with that disorder.
Exactly.
Okay.
And you will have no problem doing that. You're going to see all kinds of stuff. Yeah. And we can do that this evening too. I'm glad you're excited. I want you guys, I want you to be excited. I want you to have fun with this class. It's not an easy class, but you're going to learn a lot. Everybody, if you're working, you get through it. The people, I have very few people fail this class, and if they do, it's because they did not read or study at all. It's a very different type of nursing. Some of you will find it fascinating, some of you will find it frustrating, and it definitely brings out a lot of emotions in people. You start to diagnose people around you. You start to really start thinking about some things that maybe you never have before, addiction or anxiety. One of my other rules, I forget, I haven't had you guys. One of my other rules is you can say anything you want in this classroom as long as you're not insulting anybody else. A lot of ethical issues come up when we're discussing some of this stuff. If you want to share your opinion or we get a good debate going, I have no problem with that. As long as we're not insulting anybody. We got into a debate one class talking about the police, the role of the police in mental health arrests. There's been a lot of deaths in our country this year where people had mental health issues, were shot by the police. And something like that could be a great discussion. I want to hear everybody's opinion. Nobody's right, nobody's wrong. They're just ethical issues that are part of our everyday life and they need to be talked about. So again, anything goes in this class as long as any people are not insulted. All right. And if anybody offends anybody, let us know and we'll talk that out. So it's the other thing is these topics are not fun topics. The suicide is not a fun topic. Domestic violence is not fun. If anybody is triggered by any of these topics, you always have the right to tap out and go take a break. It's not that you're sick of listening to me, so you're going to go do something else. But I mean, if something's really bothering you, I do not want to send you into a tailspin. And this is the class and clinical. very much you need to have some outlets. And we talked about this when we did hospice. You guys got to have some outlets when you're done studying, when you're done with clinic. You're going to be listening to all kinds of stuff, all kinds of stories that may really disturb you. How are you going to go home, take care of yourself, and not get burned out? You know, I was a psychotherapist to the criminally insane. I had to have techniques when I went home, where I would get very burned out. Hear some of the stuff I heard all day long. So we'll check that. But definitely, you always have the right to tap out. If you're clinical and you need to get out for a couple minutes, let Ryan know. Go out, pull yourself back together, come on in. People's lives will really touch you. There's a lot of sadness out there. There's sad issues. All right, so class-wise, let's make sure we covered everything. And I will post for you each week, like what my plan is. Like tomorrow, I'm gonna start on chapter 2. So at least you know what to try to read before we get to class. But I'll try to stay on schedule as much as I can. I'm not great at that. Go off on tangents. All right. Anything else about class or clinical? The business part of it, right? Any issues you have? Okay. I want to do chapter 1. We're going to get chapter 1 done today. And then I'm going to give you some time to get all those tasks organized that I told you about. Can you see chapter 1?
Yes.
Okay. So these PowerPoints that I use are right out of your book. A lot of students find it helpful. Read the chapter before lecture and then bring these PowerPoints up and kind of take notes as I talk. If I tell a story or give you an example of it, sometimes appears on the test. So it would benefit you to jot down little examples that I give you. First of all, it'll help you remember the concept, but it may be a test question that I'm describing. But again, I like the book. I like PowerPoints. Pretty simple. So let's talk for a minute. What is mental illness? When you guys think of a mentally ill person, what pops into your head? And I want you to say what comes to your mind. No filter on this one. If I say mentally ill person, what are people thinking?
Chemical imbalance, like in their brain, maybe.
One more time.
Chemical imbalance in their brain.
You think about the chemicals. All right, good.
It's past trauma that maybe interferes with someone's ability to function in daily life.
Okay, yeah. Many people who have mental disorders, it's made worse by trauma or it's caused by the trauma. What else?
I think more like the genetic component of it.
Runs in families. Apple doesn't fall too far from the tree. You guys have probably heard that, right?
I like the term, I don't like the term behavioral health, and I'm glad you're using the term mental health. And I guess behavioral health tends to connote something slightly different, but it does 75% define what we're talking about.
That's interesting you say that, Steve. So there was a big, probably in the late 90s, there was this big push to stop saying mental health and everything is behavioral health. But I'm an old person and I don't change well, so I still say mental health. But it isn't just behavior. You know, it's not just somebody's behavior that we're looking at. There's so many factors. It's interesting. It's kind of like we went from mental retardation to developmental disability to try to decrease that stigma. What else do you picture when you hear mentally ill person? What do they look like physically?
Physically?
Mm-hmm.
I start to think how it impacts their life, just personal work, just their everyday function, like how they have mental issues and how it affects them every day.
Okay, so we may think maybe people are unemployed or not working because of their mental illness or can't, or lazy. So a lot of people think mentally ill people are lazy. It's stupid. How about physically? Do they take care of themselves ADL wise?
Unkept.
They can be unkept, they can smell, haven't eaten, haven't showered. They may dress very bizarre, layered clothing. Where do they live? Where do mentally ill people live?
The street.
Sometimes group homes.
Okay, so some live on the streets, some live in group homes. The majority of them live in their own homes, all over the country. But we have that. A lot of people have that image of the person under the bridge, the homeless person, drunk, high, stinking. And the reality, I guess what I'm trying to get at is the reality of a mentally ill person is 1 in 4 of us. So if we counted off 1 through 4, all the ones would be at risk for a mental health issue. 1 in 4 of us is struggling with something. And it's probably higher these days with COVID. There's a lot of studies coming out of how high depression and anxiety is right now in our country. I love when students say to me, I've never met anybody who's mentally ill. I'm nervous to go to clinical because I've never met anybody who's mentally ill. And I just laugh. You know many, many people who have mental health issues. There's anxiety in our families. There's addiction in our families. The lady that serves you your coffee at Starbucks, your doctor, your professor, everybody's dealing with stuff. The issue is we don't talk about it. There's such stigma in our country that mental health is looked as a weak. Somebody says I'm mentally ill, they are a weak person in a lot of people's eyes. Have you ever heard family members say, just pull yourself up by the bootstraps, just get out of bed, you'll feel better? And a lot of people still feel that way. There are people that do not accept addiction as a disease. That addiction is a weakness and people should just be able to stop. I don't agree with that, but
I feel like there's like such a huge spectrum of it that people, when you say mental health, issue, it's like automatically they're thinking of, like the schizophrenic person or someone with like a, something like that absolutely needs meds for. But I mean, you can even be depressed and like that's still obviously the mental illness piece, but I don't think it's as, dramatized, like, but yeah.
Yeah, and the news and movies don't help.
Exactly.
I love that stuff. I mean, I love the movies and stuff, but that just reinforces to people that the serial killer is the mentally ill person, not 100-year-old grandma who's depressed. But they both are.
Right.
That's true. Things are changing a little bit. There's been more celebrities coming out and talking about their mental health struggles. There's been suicides. There's been overdoses in the news. But we've got a long way to go. So, I mean, one thing, if you take nothing out of this class, I hope one thing is that you look at the stigma that you might think or the people around you think about what mental health is and who should get the help, who shouldn't get the help. Should a woman who killed her child in postpartum psychosis be locked up in prison for the rest of their lives? Should they get treatment? Should taxpayers pay for that treatment? There's all kinds of ethical issues. Unfortunately, it's hard to get help. Very hard to get help for a mental health issue. If you wanted to go today and get an appointment with a therapist, I mean, you could call WellConnect or something, but if you wanted to go meet with a therapist, you might wait 2 to 3 months to actually get an intake appointment. Addiction treatment same. You may wait months to go, whether you're going to be ready to go in 3 months or even alive at that point. It's another thing. But the services, you're gonna hear story after story in clinical where the system has failed us. The system has failed the person in some way. There wasn't services, there wasn't appointments. They sat in the emergency room for 9 hours and walked out being seen. So we
minimize how powerful the human brain is, and it's so incredibly powerful, and I think that that's why people kind of minimize it almost, because they're not aware of, like, you know, how much is accomplished by the brain, and sometimes it's really like something that you cannot control and you cannot help, and you can't blame that person necessarily, but that's why I think it's like a chemical, you know, imbalance or whatever, because it's something you can't help it.
I always have my brain, my glow in the dark brain here. Most powerful organ in your body. And I think you're right. And I think people are scared of it. They're scared of what the brain can do or can't do. And you could be taking your meds and going to your therapist and doing everything you're supposed to be doing, and you could still get sick. And like you said, you can't blame people. It's the chemicals sometimes. Very true. So yeah, we got to do better. We've got to do better with the mental health. So the Baker Act, you will see a lot of people Baker Acted into South Sem. And that is often a last resort for families and loved ones to have to call the police and have their loved one brought in. Very, very difficult for people. A lot of people don't want to be there. They don't think that's the tough part about mental illness. They don't think they're sick. So they're fighting along the way of, I don't need meds. I don't need to be in the hospital. The rest of you are crazy. Families, it destroys families. Families cut people off. They disown them for behaviors or things they've done. They're labeled a non-compliant person because they won't take their meds. They won't go see their doctor. You know, if you had diabetes and had to take insulin, there's just not that stigma to that as it would be if you had to take an antidepressant. People don't share things like that. So a lot of interesting topics we're going to talk about, but it's very difficult to define. And somebody said it's a wide spectrum. You can have a little mental health issue, or you can be severely mentally ill to the point you are homeless, living under that bridge. At any age can have mental health issues, any culture. And our book is culture focused. It is a very white book. So don't attack me for some things in that book. But it is important to be culturally competent because all cultures have different beliefs on mental health. And it does help us to look at all different cultures. So I do like that part of it. But just because you are from Haiti does not mean everyone from Haiti does voodoo. And sometimes it sounds like it. But culturally, it's fascinating. There are cultures who don't believe in mental illness. We're going to talk about Scientology in a couple weeks. Scientologists do not believe in mental illness at all. There should be no medication given. There's no such thing. So how do you work with a Scientologist that has a mental illness? That's a challenge. And I've had one in my life, a patient. I'll share that with you down the line. So culturally, how does the family respond? But overall, a mental illness can be a one-time thing for somebody, or it can be an everyday thing for the rest of their life. So it is very different. It is a spectrum. And it is changing. As I said, you could do everything right, and your illness can pop up and bite you in the butt. How does it affect people? It affects people personally, changes who they are as a person. It affects their relationships, ability to work, and it affects their environment. Are they able to maintain a home? Are they able to maintain a relationship? Do they end up in group homes, being able to budget? Disorders, when you see the word affect, that's emotion or what's on your face. So disorders that affect our affect are going to affect our mood, like being depressed or manic. It's going to affect our behavior, not eating, somebody not eating for weeks, being depressed, and it's going to affect our thinking, having suicidal thoughts. So mental illnesses are very much overpowering, overwhelming. They take over people's lives. And unfortunately, we don't see people till often they're at their bottom or they're in distress, suicidal, on the verge of physically dying because they haven't been eating. It's often, we see people at the end sometimes when they're Baker acted. Remember that upstream and downstream intervention, we should be doing more upstream, working with children early. Okay, many people with mental illness are dissatisfied in the world. They are not happy. They feel there's nothing wrong with them, as I said, that everybody else is crazy, they're bothering them, and it definitely stops satisfaction in life, relationships, and personal growth. So people get stunted. You know, thinking about Erikson's stages. Those theorists say that when somebody gets mentally ill, they stop growing developmentally. So you may have a patient who's 35 who's been schizophrenic since they were 16, and they may act very much like a teenager in a lot of their behaviors. That's because developmentally they're stuck in that area. They say the same for addiction also. Once you start using a substance, you stop growing emotionally, developmentally. All right, our Bible, for those of us who work in mental health, our Bible is called the DSM. The Diagnostic and Statistical Manual of Mental Disorders. There are several copies in the library at school. I'm sure you could get it online. If you plan on working in mental health, it's worth buying a little pocket copy. It basically outlines every mental health diagnosis there is. It bullets the criteria that someone has to meet as far as being diagnosed with that. And it talks about functioning. It's not nursing diagnosis. It's not medical diagnosis. It talks about how someone is functioning within their life with that disorder. I tell students it's a great way to study. I mean, if you're having trouble with schizophrenia, pull the DSM out and open to schizophrenia. It'll bullet point to you. Patient needs to meet 6 out of 10 of these criteria to be diagnosed with schizophrenia. It lays it right out there for you. Patients find it actually very comforting to see that in a book. This is me. I meet 6 out of 10 of these, so this is what I am. The DSM will also give you a period of time. Somebody needs to exhibit this symptom for 6 months. Not just a week, not just 2 weeks of their life, but a 6-month period. So that's our DSM, and I'm going to teach you down the line how to label somebody with DSM criteria. We have what's called 5 axis, AXIS axis, and it's a blueprint of a patient. So you have 5 criteria listed, and it tells you exactly what's going on with that client. That's one of the things you're going to be learning how to do is to write those. This is also, the DSM is also how we bill people for their stay at the mental health facility, which is about $2,000 to $4,000 a day usually for a stay in a secure mental health facility. Between everything they're given and security and nursing and but that's also how they build the hospital bills people. Questions about the DSM?
I have a question about the axes. Is that what they're called?
Mm-hmm.
I thought with the new version of the DSM, I thought they got rid of the axes or the axis, whatever you call it.
They got rid of Axis 4, which is they did away with it, which is psychosocial stressors. But because I hate change, I make you learn it anyway. But they did the last revision, they made some changes. So every time this book comes up, people get together and they make changes. Homosexuality used to be in this book. It is not a mental health disorder, but at one point in history, it was in this book. PMS.
Hysteria.
Hysteria. PMS has been used as an excuse for killing somebody. That's been in this book. Autism and Asperger's is one they struggled with the last edition. They made some changes on that I don't particularly like either, but yeah, times change, thoughts change about what's a mental health disorder, what isn't. Yeah, everyone was hysterical. Everyone had schizophrenia. Women all had to be medicated. And I love the history of mental health, and we'll talk more about that as time goes on. And if you remember, I did my little Halloween talk for you. That was a long time ago. But we really did that stuff to people. We really did lobotomies and ECT without anesthesia. All right, so when I show you an example of your case presentation, I'll show you more about the axis. But they have made some changes, you're right. I don't deal well with change. All right, so historical times. Mental health issues have been with us forever. People would think that someone was possessed. It was a curse. Different cultures believe all different things. I am a Catholic, and you can actually you can request a assessment for demon possession. And I actually had a patient that requested that of himself. And the Catholic Church sent somebody to do an assessment to see if he was possessed. But that is something that's, in the history, that's in the movies, and it still is done periodically today. So he was not possessed. He had schizophrenia, but that it was his right to have that assessment. But your book goes into it more. It's fascinating though. We did what we could at the time, I guess. A lot of it was inhumane. We had no meds until 1950. We were just trying to control these bizarre behaviors, suicidal thoughts with whatever we could. We talked way back when. I can repost my Halloween thing if you want to look at it again. But we had asylums. We basically took people that we didn't want to see in the community, and we took them to an area outside of town or on an island and put everybody there that we didn't have to look at. And that's where they lived their life. And that whole concept that you learned in public health about deinstitutionalization and bringing people back to the community, back to the streets, we're trying. We don't like locking people up. I mean, today a Baker Act is 72 hours, and that's probably, if you get Baker Acted, you're lucky. If you get 72 hours in the hospital, you're lucky. But very different than being locked up your whole life because you had anxiety or because you were homosexual or had a physical disability. Okay, again, drugs in the 50s opened up a whole new world for us. Everyday stuff is coming, different drugs are coming out that are helping people. I do believe, and this is just my opinion, we are, and I'm as bad as everybody else. We are a society that wants a quick fix, and we want a pill that's going to take things away quick. That's why we have so much addiction in this world. Drugs are wonderful, they work, but a lot of people will go for an antidepressant or an anti-anxiety medication and don't want to do the therapy or the talk part of it. They just want the quick fix. I believe there has to be a little bit of both. You have to have the talk therapy and the medication to work together to go towards what we call recovery. Our ultimate goal is recovery, to live the best life possible. Mental illness is a disability, so people do get a monthly check. If they qualify, they do get, it's not a lot, they do get a monthly check for their disability. So here comes that stigma again. We think people are just faking things so that they can get their monthly check. But if you can't work, you can't work. How do you buy food? It's a tough one. And commitment laws are the Baker Acts, and every state has a different Baker Act. Baker Act is just for Florida. Depending on what state you're in, the commitment laws are a little different. But basically, it's the right of the authorities to pick you up and put you in the hospital or observation against your will for a certain amount of time if you're a danger to yourself or others. Just know that it does vary from state to state. Insurance is a challenge. I can tell you, if you have good insurance, you probably get 2 weeks a year for mental health services inpatient. And 2 weeks is nothing if someone has an addiction or if someone has a pretty severe depression. And you will see people leave the hospital before they are really ready, trying to save some of those days for later in the year when they may need to be rehospitalized. Addiction, there's theories in addiction, you need months of sobriety, supervised sobriety, before they can stay sober. 2 weeks is nothing. A 2-week program or a week program is nothing for people. You're barely detoxed, and they're sending you back. And if you have no insurance, it's even more of a challenge. So when we talk about universal health care, we talk about Obamacare, all those programs, one thing that I always look at is the mental illness coverage. What are we covering for mental illness? And the other thing is people have rights. So if you're over 18 and you're saying, I don't want to be in the hospital, I don't want treatment, I don't want medication, we have to respect that. You can't force that unless you're a danger to yourself or others. The families, and I'm sure some of you have been through this, families get extremely frustrated. They know their loved one needs help. They get it for them. They don't follow through. And there's nothing they can do. And unfortunately, sometimes bad things happen before the person gets the help that they need. So it can be very frustrating. Children are a little easier because the adults can sign them into the hospital as far as getting them treatment. The children suffer the same things that adults do. Pretty much every diagnosis that adults do. Okay, so again, 1 in 4 of us, about 26%, and I bet that's higher, have some diagnosable mental disorder right now. Look at the last sentence, guys. Economic burden of mental health issues exceed that of all types of cancer. That's pretty amazing. So meaning people are missing work, hospitalizations, suicide. The economic burden of that is worse than all the types of cancer together. The number 1 in the United States right now is anxiety. Number 2 is depression. And they often go hand in hand. So some people have got both of them. They are often called cousins. Leading cause of disability in our country today is mental illness. and increasing numbers of people who need treatment, and particularly children and adolescents. So with COVID, there's a lot of research going on right now about COVID, the percentage of depression that's occurring, addiction, isolation, suicide, domestic violence. So we're going to have more and more numbers, and they're not going to be good, as time goes on. The good thing is they're doing a lot of virtual therapy. These companies are popping up where you can call a therapist. It can all be by phone or text. I mean, you got to have money to do that. But the world is definitely changing as far as therapy. And we've all been to the picnic project. We've seen that the homeless or the food, people are suffering from lack of food. They are in need. The services are not always out there. Challenging. So what we get, what you're going to see at South Sem is called the revolving door effect. You will see the same people. You will probably see the same people hospitalized a couple times while you're there. And that's the revolving door effect. They get Baker acted, they go in for 72 hours, they get on meds, they start to clear, they're doing great. They put together a great discharge plan, they're out the door, they stop their meds, they start using again, they're Baker acted again in another month or so. That's the revolving door. Those of us that work in mental health, we see the same people over and over. They get to be like family. And children too. I saw the same kids at Halifax come in over and over. And that's our fault. That's really our fault. We don't have the services to follow up with them after hospitalization. And then the thoughts of mental illness, that I'm not mentally ill, that pops up, and then people stop taking their meds. All right. One of the issues we've been struggling with the last 20 years or so is physical illness, comorbidity. So what happens, we're going to learn about this tomorrow, the new antipsychotics, the medicine that they've created for schizophrenia or thought disorders, they work great. They have some side effects, they work great. One of the side effects, unfortunately, is weight gain. So if I'm schizophrenic and hearing voices, I can get on a medication like Zyprexa to take my voices away, gives me energy to go to work. I'm functioning, but I just put on 60 pounds. So from the physical side, I can develop diabetes, I can develop high blood pressure, I can have a stroke. We are seeing people, this would be a great research project, we are seeing people die about 20 years earlier who have a mental illness than people who don't. Part of that is how they eat, chemicals they use. They may not have access to good food, that sort of stuff. But there are so many physical comorbidities. So again, you may say, I don't want to be a psych nurse, but you're going to have 6 patients in the future on your shift, all in heart failure, and probably 3 of them are going to have mental health issues. They're going to end up in your hospital bed. So again, this is the time to practice that stuff. How do you talk? How do you talk to somebody who's hearing voices? How do you talk to somebody who's seeing things that aren't there? So it's a good time to learn this. Have you heard enough about Healthy People 2020 for the rest of your life?
Yes.
Yep.
Yes. And I won't ask you about primary, secondary, maybe. We'll see. Things we're looking at right now are the effects of COVID. We have high suicide rates in our country, particularly among veterans and young people. Homelessness is one of our focuses right now, are transgender transgender, gender identity, people that are struggling with that, being thrown out of their house, suicidal on the streets. That's for Orlando. Actually, that's one thing that they're really focusing on. Great organization that you'll learn about called Zebra Coalition. They're trying to help some of these kids who are on the streets and struggling right now. Or even doctors. They're trying to educate us how to be culturally competent with that group, how to help, what doctors can help and what nurses can help them. Employment's an issue. Going to school. Can you imagine going to school, hearing voices, or seeing things? That when you fill out a job and it says, have you had mental health issues, or are you on something? Sometimes they ask about medication, or you've been arrested. Those are all questions that people struggle with on those forms, to be honest or not to be. There is stigma around mental illness. There's definitely, people don't get jobs if they admit to it at times. That is very true. Incarcerated persons. So the biggest mental hospitals in our country are our jails and our prisons. And they usually don't have because they don't have to take them. So there are many people sitting in a jail cell or prison cell right now, hallucinating, suffering. And if you have an interest in forensic nursing, it's a big area right now. You can make a whole career out of that. And there are mental health services in the community. We don't have enough, but they are out there. Trying to move more people in the community to have their therapists there, their treatment there versus in the home. Much cheaper. Got $2,000 a day versus maybe $600 a day to go to an outpatient program. The ones that are Baker acted or end up in the hospital are usually, as I said, severe. They're probably suicidal. You pretty much have to be suicidal with a plan and very few resources at home to get hospitalized. If I got 2 beds, I'm working in the emergency room, I've got 2 beds. Sorry, I got 2 suicidal people. One, their family's there with them. One is a homeless person. Unfortunately, that person without resources is going to get it because they're at higher risk for the suicide without the family. Okay, we talked about insurances. There is definitely differences in the mental health services, different cultures, different groups get. And a lot of that is because of their beliefs. A lot of cultures don't want help. They don't want the medicine. It's the stigma of it. So there is a lot of different stuff to break through there. Trust of the healthcare providers. Okay. A little history. Psychiatric nursing has been in the curriculum for the BSN for a while. Some schools are integrating it into their clinicals, but I very much think it's important to have the class and to learn everything that you need to learn about mental health. You will always use it. We'll talk about Peplau tomorrow. She's my favorite theorist, but she is the one that says that you as a nurse are the best tool. You can be the most therapeutic tool to help somebody just by being yourself. Okay, so as far as psychiatric nursing, you can walk out of ECPI job in a mental health facility. They prefer that.
Hello?
I don't see anything either. I don't hear her.
I thought it was just my internet.
I think it's hers.
She looks frozen.
She got kicked out?
Yeah, I bet.
Oh, okay.
She is.
Every so often, yeah, my computer's like, yeah, you've been talking way too much. Okay, sorry. We're almost done. Hang in there.
The last thing we heard was you were saying you could get a job as a mental health nurse right out of ECPI.
Okay. All right. So yes, a lot of facilities around here will hire new grads. So they prefer that because they can train you. But there's a lot of people that go do other stuff and then come back to psychiatric nursing. The nurses that you will meet at South Sem, they are bachelor's prepared nurses. That is a magnet hospital, I believe. And what do? They do basic level functioning. They do admissions. They do discharges. The nurses at South Sem will give medication. They will help with showering or taking care of the person physically if they need to. Health teaching, making sure people are eating, they know their meds, family work. So at a higher level, so master's prepared, nurse practitioners, they do psychotherapy. So again, my last job before coming to Florida, I was a psychotherapist. I did psychotherapy with a group of people. Nurse practitioners can prescribe drugs. You could be a consultation liaison nurse. So you could be working on a PEDS unit, and you could ask the psych liaison nurse to come over and give you their opinion on this eating disorder patient. So there's usually one or two in each hospital that are psychiatric consultants, and will come over. And then higher level nurse practitioners, they do a lot of the evaluation, diagnosing. They work under a doctor. But definitely new grad, if it's something you're interested in, you can definitely walk out and get a job. I've got a couple of EPI alumni are working at South Sem. I think they're working night, so you may not meet them. But a couple of the other hospitals have picked up some of our graduates also. The nursing role, I just have to say, the nursing role is not always the best that you're going to see, just because of the bureaucracy and the paperwork and the burnout of nurses. Sometimes it feels like the nurses are behind the glass, just like in Ratchet, behind the glass, and everybody else is out in the milieu or out in the day area. You may not have a lot of contact with the RN at South Sem. That's okay. It just happens to be the way the role is. And burnout doesn't help when people get in this role and they kind of stay there forever. Your best friend when you get to clinical can be the psych tech, or the person that's running the floor. They're out there all the time with the patients. They are the best resource of who to talk to, who not to talk to, what's going on with somebody. They do report to the nurses, but they often know much more than the nurses about what's going on out in the milieu or out in the area. So it'd be interesting to hear what you think when you start clinical. But the nursing role that students have observed has not always been a great one, unfortunately. You get to these higher levels and it can be. I mean, I loved what I did at an advanced practice level in New York. I was one of only 2 in the whole state that did psychotherapy like that. But you could very much, as you go on in your education, you can make that yourself very marketable and very specialized. Any questions about what a psych nurse does? Their ultimate goal is to connect with their patients. I've seen nurses get on the floor under the bed with a patient who wouldn't come out from under a bed. However, you can use yourself again to help somebody, comfort them. somebody. Okay, so what some student concerns that you might have, you might be thinking about. The one big one is saying the wrong thing. There is no wrong thing. I mean, you can be therapeutic or untherapeutic in your communication, but you are not going to set a patient off by what you say. If somebody is in a bad place and you just say good morning, that could be enough to make them angry. So don't take things personally. Practice that therapeutic communication, but if you make a mistake, it's okay. I make mistakes after 35 years. You just admit that you made them and go on. You may not always know what to do. That's okay. Mental health changes minute by minute. In nursing, you always kind of have to be able to go with the flow. You may have an agenda for your shift and it just may not go the way you want it to. So you might not always know what to do, but you can keep people safe. You can respect people and give them the best care that you can. Don't worry about if you're rejected or you walk up to meet somebody and they don't want to talk. It has nothing to do with you. It is just where they are at that moment in their life. So remember, the people you're going to meet in the hospital are at probably one of the lowest points of their life. They've been hospitalized. They're suffering. They're embarrassed. They're angry. So if they don't want to talk, it has nothing to do with you. If they ask you personal questions, so we're there for the patient. But a two-way conversation is normal for us. And if they ask you personal questions, the rule is you can divulge or share information about yourself, not too personal, if you feel like it can help the patient. They have a right to know who you are. So your name, we use first names only. And we use, and they have a right to know you're from ECPI, you're a nursing student. But we don't share Facebook, we don't share phone numbers, we don't share emails, we don't visit after the rotation is over, we don't keep in contact. Those things have to be laid out right when you meet your patient. So, I mean, you'll get questions like, are you married? Do you have children? If you think it's appropriate to the conversation you're having, or it would help you connect with that person, it's okay to answer yes or no, but then turn the conversation back to the person. Yes, I do have children. Tell me about your children. Now, if somebody's asking provocatively, like, can we date? Can I call you afterwards? You guys might get some of that. The answer is no. We're here for just 8 hours. We can't be in contact with you afterwards. It wouldn't be professional. You have to maintain boundaries. And then you would let Ryan know or the psych tech that's happening. Yeah, I mean, if you don't know what's, go ahead.
I was gonna say, I'm glad you addressed that because I don't think that's really been covered a lot, like of what's appropriate and what's not. And not like we don't know right from wrong, but like I think in a clinical setting, and my mom just got her mental health, her master's in mental health counseling, and like she had one of her patients give her like a present or something, and she had to return it, and it was something that like he made and whatever, but like I guess that's off limits too, Yeah. But I wasn't really thinking along those lines because I'm a very friendly, like kind of raw and open person. And so sometimes I would, I don't know, I needed to watch myself, I think, with how comfortable I was with patients and stuff. So, but my mom said mental health counseling and the mental health setting is also like almost just more intense rules and guidelines to follow.
Right. I mean, it might seem ridiculous giving that little gift back, but it could be made into a bigger thing down the line. I gave you I gave you this and now you should be able to answer my phone call.
Yeah, you're basically like covering your butt.
Yeah, and we're all different. Some of us are very outgoing. I'm very touchy-feely. That's something I have to work on, touching people. But the rule is kind of, if it helps the person, share it. Because we're not robots, and they want to know. They want to know about you a little bit. I just told you my whole life story. I would like to know a little something about you. They like to hear, share things like, I've seen students share about how stressed they get with tests and how school is. And like the teenagers will think that's so cool. Wow, you get stressed at tests? Maybe I'm not so unusual then. That kind of stuff. Or if you have children, if you're married, tell me about your husband and bring it back. So you're not giving out too much information. You're not saying where you live, If you're telling the patient your problem, then you've given too much. But if you could share a little and bring it back, that's the best way to do it. And if you're out of options, even with the personal questions, my instructor won't let us do that. We can't come visit afterwards. We can't write to you. You always blame it on the instructor. The one time that I saw it work really well is I had a student once who was a diabetic, and she, for some weird reason, ended up working with a young girl who was just diagnosed with diabetes. And she came to me and was kind of like, I kind of want to share that with her and share my experience. What do you think? And I was like, go for it. She shared that with the young girl. They were kind of the same age when they were diagnosed. They talked a lot about it. And the patient actually got a lot of support from her because they had a shared experience. Does that make sense? They had something that they shared. They could connect. It helped the person. It helped the patient. But if you don't know, run it by the clinical instructor. They can help you sort that out. But the boundaries, that you have to keep the boundaries pretty strict. Only because of the bizarre thinking, and people get attached to you very easily. Think about, these are people that nobody talks to them except people who are paid to talk to them. So here comes a nursing student and they're going to talk to me, and they can become very attached to you in 8 hours. So you have to lay out those rules. I'm only here for 8 hours. I'd like to learn about you. I'd like to learn about mental illness, mental health. But after the 8 hours, I probably won't see you again. I know that sounds harsh, but it's kind of how you have to lay it out. Any other questions that people are concerned about that they might get from clients?
Is there like a client's profile or that we can look up or before we go into clinical or something like that?
A good question. So you're going to have access to their charts. You're going to have access to all their information. You won't have it the night before, but you'll have it. You don't have to work them up the night before, but you'll have it there. I encourage you guys to go in and meet them first before you look at their chart. Why do you think I do that?
To prevent any
So we don't judge.
bias.
Yeah, you read somebody's history and you have a preconceived notion of who they are before you even meet them. And they may not be the same person that they were Baker acted 3 days ago, now that they're on meds. I think Ryan and I disagree on this. I'll have to ask him, but I'm a big proponent of go meet your patient first. You always have to be careful. You're not going to put yourself in any unsafe situation anywhere, no matter what kind of floor it is. But yeah, you will have access to all that. They just try to keep an open mind before you read. But sometimes they tell you this whole story, and then you go back and read, and none of it is true. They've made up a story, or I'm being taken advantage of, and you can see that this is their 15th hospitalization in the last 3 months. So yeah, you'll be able to compare and look at charts. Any sexual stuff though, or people are being provocative, just shut it down. I can't talk to you when you're talking like that. And usually they'll pull it, they'll stop doing it because they like the students actually talk to them. It's kind of benefit to have a student. But if you feel uncomfortable or just, I gotta go find my instructor, let the psych tech know what's going on. You get stuff in med-surg beds too, people being provocative, and how do you deal with it? You will see some bizarre, inappropriate behaviors. Could be sexually aggressive. We're going to practice something called the poker face, and the poker face is just keeping that non-judgmental expression on your face. You may see somebody acting very bizarre or come out with no clothes on or masturbating or whatever it might be. You have to keep that poker face. You can't laugh at them. And that's where I'm talking about the acceptance and the being non-judgmental. We're obviously the staff is going to stop that, but to make sure people are not embarrassed, protected for their privacy. People aren't laughing or making fun of them. Again, psych tech, great person. Anything you see that they don't notice, let them know what's going on. Feeling unsafe. So nobody should be unsafe in this rotation. I've been doing this for 30 years and I've never had a student hurt ever on a mental health unit. And we were on forensic units for many years. You use your gut feeling. If you feel weird about something or somebody staring at you or you just don't feel right, let the staff know. Get out of there. We're not going to put you on a unit that's not safe. That being said, things do happen. We have psychiatric emergencies or codes where things do happen. Your job in those situations, if a fight breaks out or something goes down we're all together in the day area, if something goes down, your job is to go get out of the way, go sit with the other patients, or staff removes you from the unit, follow their direction. We're not going to put you in an unsafe condition, but use that gut feeling. If you're feeling uncomfortable about somebody, let somebody know. That's your best tool that you have there. They're people. They're just people having a very bad day, and they like talking to students. I don't think you're going to have too much trouble with that. Staff's a different story. Staff has control over them. Staff can say if they can leave or not. So they often can argue with staff and feel threatened by staff. You guys don't have that over them. Anybody feeling unsafe or having issues with going into a mental health unit? They are locked units, so you'll have, when you travel from unit to unit, you'll have to wait till somebody lets you in and out. You won't have keys. There's enough of you in each group, so there's probably going to be 2 of you on each of those units. So there's 4 units, and Ryan maneuvers all the way through. So at least you'll have a partner, and it's okay if 2 of you sit down and talk with somebody. As long as it's like a 3-way conversation, it's just fine. The other thing that comes up periodically, and it's not unusual, is if you know somebody who's on the unit as a patient. Please don't pretend you don't know them. Let Ryan know. If your next door neighbor gets Baker acted tonight and you have clinical tomorrow, please just text me and let me know that. So we got to make sure that you're not on the same unit with your next door neighbor or your relative or whoever. It happens. As I said, in mental health, mental illness is in all our lives. And I've seen it handled very successfully. I had a student who, we were on a unit, and there was a kid he went to high school with. They were high school classmates together. They were probably in their late 20s now. And they knew each other from high school in their small town. They didn't work together as patient and nurse, But they would take about 10 minutes at the start of each clinical day and sit down and just talk about high school, talk about the town, kind of stuff that they shared, and then they went their separate ways. And I loved the way the students dealt with that, because he's not pretending he doesn't know you. He knows you. But you're not doing therapy or you're not doing interventions with that person where it would be. So if you do know somebody, just let us know. Believe me, it happens, and we can work around it. I have had students who were patients on the floor that they're going to for clinical. And I've been able to work through that or move you to a different place or whatever it might be. That happens too. So. All right. We're going to talk about people similar to us. There's something called transference and countertransference, if you've ever heard of that. It's actually one of Freud's theories that are still around. Freud did a lot of weird stuff, but that's one that he did that's still around. Long story short, it means we are drawn to people who are like us, or we are drawn to people that we have good feelings about. So if Steve looks like my brother and I like my brother, I'm going to be drawn to Steve. That is transference. Countertransference is when the nurse is drawn to a patient because of characteristics the patient has. I have a little old depressed grandma that I love, and here's this woman, she's got dementia at South Seminole. She looks like grandma, so I'm drawn to her. Oh, you poor thing, I want to work with you, I'll help you shower, I'll take you to group, let's go do this. That's countertransference. It can be negative in that therapeutic relationship because you're taking on somebody because of the characteristics they have. Does that make sense? It's a real thing. You got to be aware of it. If you feel like you're being drawn to somebody, just run it by Ryan. It can be worked out. It could be good or bad. I'll give you another example. When I worked in the forensic unit, we got a 16-year-old kid once who he went into a grocery store, took a knife out of the hardware area, and he randomly stabbed a woman in the eye. Ended up in our place. This kid looked like he was a teenager. He was a skateboarder, you know the look. And I had 3 of them at home. I had 3 teenagers with the whole look. He was not my patient, but I found myself going to visit him at the hospital, bringing him Skate Party magazines, talking to him. And I had to stop myself and say, wait, this is not right. I'm not part of his treatment team. There's no reason I should be spending time with him. So we who work in this area, we use supervision a lot. You have to talk out that stuff with your supervisor. It's normal. That countertransference is normal to be drawn to people that are like you. And Ryan is your supervisor in this case, or me. And you can run things by us. Boy, I'm really drawn to this patient. I don't know why, or this patient's annoying. I can't even listen to him. I've got a brother similar to this. So transference, countertransference. People will, when you walk into the milieu, you walk in next week, they will check you out. There will be people that go right on to you. Melissa, you look just like my sister. And just people will come right up and start talking to you. That's a very real thing. You can use it positively or negatively. Got to be aware of it. To try to get out of your comfort zone. If you hate kids, try to go to the kids unit maybe twice, or challenge yourself a little. If you don't like older people, challenge yourself a little. All right, what kind of questions do you guys have?
Are you setting up our logins?
Oh, for self-sem? For the computer?
Yes, yeah. For Orlando.
Yeah. Professor LaRoche is setting that up, and that's part of the EPIC training. You'll have all that.
Thank
Do you guys have badges for Orlando Health?
Yeah.
Yes.
Everybody does? Okay. So you'll need that badge. You'll need that badge and your your name badge for ECPI. But you need 2 of them. You can cover up last name in this rotation. So if you want to take a piece of tape and cover up last name, there's no problem with that. We do that a lot. Just because with social media, they don't need to know your last name. Other questions? The one thing I didn't mention is this is a 4-hour class. You probably figured that out. We do go to 5 o'clock every day. A little longer than public health was. All right. I want to end with a quick video that we're going to take a look at. It's a girl with schizophrenia. It's a little over 10 minutes, and she's going to talk about what it's like to have schizophrenia and the stigma of people looking at her. Let's take a look at that. Where are you?
Hello, my name is Cecilia McGow, and I'm an astronomy and astrophysics major here at Penn State, and the founder and president of the Penn State Pulsar Search Collaboratory. In high school, I was lucky enough to have co-discovered a pulsar through the Pulsar Search Collaboratory. A pulsar is a super dense neutron star that emits dipole electromagnetic radiation. So basically think of a star much, much larger than our sun, blowing away its outer layers, leaving behind a dense core. That core could be our pulsar. This discovery opened some doors for me, such as helping represent the United States in the International Space Olympics in Russia, and also being a Virginia Aerospace Science and Technology Scholar. I know what you guys must be thinking. What a nerd. Nerd alert! Well, for the longest time, this nerd had a secret that I was too scared and too embarrassed to tell anyone. That secret is that I have schizophrenia. But what is schizophrenia? It's important to think of schizophrenia sort of as an umbrella-like diagnosis. NAMI shows these different symptoms as ways you could diagnose having schizophrenia, such as delusions and hallucinations being sort of the hallmark type of characteristics. But it's very important to know that a person can have schizophrenia and not have delusions and not hallucinate. Each person's story with schizophrenia is unique to their own. Today, I'm going to be talking about my story with schizophrenia. It's been thought of that I've had schizophrenia all of my life, but it became very prevalent my junior year of high school and then just snowballed into college. February of 2014, my freshman year of college, my life changed when I tried to take my own life through suicide. Why, you ask? Because my life had become a waking nightmare. The following images have been edited using Microsoft Artistic Effects because they are just too triggering for me. At this time, I started hallucinating, hearing things that weren't there. Everywhere that I went, I was followed around by a clown that looked very similar to the Stephen King's adaptation of It. Everywhere that I went, he would be giggling, taunting me, poking me, and sometimes even biting me. I would also hallucinate spiders, sometimes little spiders, and these are actually the most obtrusive sometimes because we see little spiders in real life. So sometimes this is the only time I get discerning whether it's a hallucination or real life. I'm very good at knowing when I'm hallucinating. And I know that it's a chemical imbalance inside of my head. I don't give these hallucinations even names. I also hallucinate giant spiders though. One spider in particular comes to mind. It was rather large, leathery skin, dark, black legs, and yellow body. No voice ever came out of its mouth. However, when it moved its legs, the creaking of the legs sounded like young children laughing. It was very disturbing. But it started becoming unbearable when I started hallucinating this girl. She looked sort of like in the movie The Ring. The thing with her is she was able to continue on conversations with herself and would know exactly what to say and when to say to chip away at my insecurities. But worse was she would also carry a knife around with her and she would stab me, sometimes in the face. This made taking tests, quizzes, and doing homework in general extremely difficult to impossible when I was in college. Sometimes I wouldn't even be able to see the paper in front of my face because I was hallucinating too much. I don't usually speak so openly about my hallucinations because people usually look at me in fear after I tell them what I see. But the thing is, I'm not much different than the rest of you. We all see, hear, and feel things when we're dreaming. I'm just someone who cannot turn off my nightmares even when I'm awake. I've been hallucinating now obtrusively for about over 4 years. I've gotten very good at just pretending I'm not seeing what I'm seeing or ignoring them. But I have triggers, such as seeing the color red is very triggering for me. I don't know if you guys noticed this or not, but they changed the carpet that I'm on. They changed it to a black carpet instead of red. I sort of laugh at my life a bit like a dark comedy because, of course, the only combination that I have issues with is red and white. What is Ted's colors? Really, people? But I have issue with those colors because those are the colors that the clown has, red hair and white skin. And how I'm able to ignore him is I just don't look at him, but I'm able to know where that hallucination is in my peripheral vision because of the bright colors of red and white. But you never know that I'm hallucinating. The clown is actually in the audience today, and you would never know. On a lighter note, who's looking forward to the Oscars? Hands up? Anyone? Oh, yeah, I knew you guys would be interested in those. Well, if there were nominations for people just acting normal in everyday life, people who have schizophrenia would definitely be nominated as well. When I first became open about having schizophrenia, it was a shock to even the people closest to me. It took me 8 months. 8 months after my suicide attempt to finally get the treatment that I needed. I didn't even have the diagnosis of schizophrenia. And because of that, what kept me from getting help were conversations like these. I remember very distinctly within that time on the phone with my mother. I would tell my mom, "Mom, I'm sick. I'm seeing things that aren't there. I need medicine. I need to talk to a doctor." Her response? No, 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 no. You can't tell anyone about this. This can't be on our medical history. Think of your sisters. Think of your sisters' futures. People are going to think that you're crazy. People are going to think you're dangerous, and you won't be able to get a job. What I say to that now is don't let anyone convince you to not get medical help. It's not worth it. It is your choice, and it is also your right. Getting medical help was the best decision that I've never made, and I am confident that I would not be here today if I didn't get the proper medical help. This led into my first hospitalization. I've been in the psych ward 4 times now within the past 2 years, 2-ish years. But I still was not open about schizophrenia, my second hospitalization, because the police were involved. One evening, I realized I needed to check myself back in the hospital because I needed some changes in my medication. So I admitted myself into the emergency room. I talked to the doctors. They said, okay, let's fix the meds. You can stay here overnight. It was all good. After the hospital, the brief one-night hospital stay, I came back to my dorm here at Penn State, and to very concerned roommates, which I understand why they were concerned. If I was in their shoes, I would have been concerned as well. But also the RA and a can-help person. We all talked, and we decided that I needed to have another psych ward stay. And I was okay on going. I wasn't at all refusing, and I was willing to go. But what happened next was inexcusable. They brought police officers into my dorm room in front of my roommates. They patted me down, and I had to convince them not to put handcuffs on me. They then escorted me into a police car that was parked on the road next to one of our most common dining commons, Redifer, where friends were passing by and seeing me put into a police car. By that time, when I came back, the cat was out of the bag. People knew something was up, so I had to set the story straight. I opened up about my schizophrenia through a blog, but I posted all my blog posts on Facebook. And I was amazed about how much support that was out there. And I also realized that so many other people just like me. I was actually amazed. A few of my friends opened up to me that they had schizophrenia. Now, I am dedicated to be a mental health advocate. I'm not going to wallow in self-pity about my diagnosis. Instead, I'm going to use it as a common denominator so it could help other people who have schizophrenia. And I am not going to rest until anyone who has schizophrenia worldwide is not afraid to say the words, I have schizophrenia. Because it's okay to have schizophrenia. It really is. Because 1.1% of the world's population over the age of 18 have schizophrenia. That is 51 million people worldwide and 2.4 million people in the United States alone. There's a problem. Because 1 out of 10 people who have schizophrenia take their own life through suicide. Another 4 out of 10 attempt suicide at least once. I fall into that statistic. You would think that there would already be a nonprofit focused on empowering college students who have schizophrenia, especially since the peak age to have a schizophrenic break is early adulthood, the same age range as a typical college student. But there isn't. There is no nonprofit in the entire United States focused on that. And a general nonprofit focus on mental health in general is not enough, because even in the mental health community, schizophrenia is shied away from because it makes people feel uncomfortable. That is why I've decided to found the nonprofit Students with Schizophrenia, where we will empower college students and get them the resources that they need so they could stay in college and be successful. Because you could be successful and also have schizophrenia. We need to change the face of schizophrenia because the representation currently is inaccurate. Don't let anyone tell you that you can't have a mental illness and also not be mentally strong. You are strong, you are brave, you are a warrior. Unfortunately, this nonprofit is too late for some. Since I've become open about having schizophrenia, I am asked to come into different classrooms here at Penn State and talk to the class about my experience having schizophrenia. One class stands out in particular. Earlier in the semester, one of the students opened that she had schizophrenia. I commend her for her bravery. However, by the time that I came and talked to that class, she had taken her own life through suicide. We were too late for her. I was too late for her. Here at Penn State, we have to make an example to the world, because this is not just happening here at Penn State, it's happening globally. But here at Penn State, we have to show that we are here for our students, we are talking about mental health, and we are not afraid to talk about schizophrenia. My name is Cecilia McGow. I have schizophrenia, and I am not a monster. Thank you.
What do you think, guys? Thoughts? Anybody?
We didn't hear you.
Oh, I thoughts on that.
Yeah, we lost you again.
Can you? No. Hang on. Can you hear me now?
Yep.
Okay, I just wondered what your thoughts were on her talk.
She was positive and it came off as very like inspiring overall for like mental health, not just schizophrenia. She like led like a really good example.
Yeah, I liked it because, it shows people that you can live with it, like it's not it's not a disorder that, you're bound to, live, on the street or, have problems for the rest of your life. If you control it, then you can have a productive life.
Mm-hmm.
Yeah, I liked that she didn't let it define her, and she's more than her illness.
Mm-hmm. I mean, imagine how scary that is for her to go through and to be able to speak up about that. And, the reaction from her mother is very common. And that's just the stuff of our society. It scares us. We don't want to talk about it. Don't tell anybody. It's embarrassing. Shouldn't feel that way. Just go out, exercise a little, eat better. Good. I thought that'd be a nice way to end. Definitely explore the stigma during this semester. Challenge your friends. Get in a fight with your talk about this stuff. Very relevant. Yeah, and I think you're going to be shocked of the patient that you meet at South End. That patient could be you. It could be me. You're going to be very surprised. It's a very fine line. Who has the keys who has the keys to the unit and who doesn't. So, all right, couple housekeeping stuff. Jody says you guys should have had a email that had codes to the points, a course point plus product, the point lww.com. Does anybody recall that? That
Yeah,
is your book.
I downloaded the book with the code
Okay.
and it works.
Yay! So this evening, everybody get those downloaded. I am gonna start with chapter 2 tomorrow at 10 o'clock when we're together. So if you've got time, it would benefit you to take a little look at chapter 2. It's a bear. Okay, so that's the book. I am gonna post the clinical schedules as soon as I get off with you, so that everybody can take a look at it. If you have any issues or questions, let me know. So I'll post your clinical schedule and I'll post the sim schedule so you can get that all figured out. So the other thing I will take from people between now and tomorrow is email me, one person email me with your group for the case presentation, phone or whoever's in your group, and I will email you back with a topic and the date so that you can start organizing that. And tomorrow, I promise I'll show you an example of one of the case study presentations. Okay?
Okay, just to confirm on that, you want us grouped in according to days, like Tuesday groups, only work with Tuesday people?
I just suggested that, Grace, that like if you wanted to use somebody from clinical, but if you want to mix it all up and make a patient or take a celebrity, that's fine too. I was just making suggestions. It could be anybody up to 6 people that you'd like to work with.
Okay, thank you.
If you have a topic that you're really or diagnosis you're really passionate about, you could suggest it to me. I can't guarantee it, but I'll look at it. It just if you want to work with a clinical group, it makes sense to kind of who's in your clinic, who's going to be there the same days as you. So, all right, that's all I've got. Has anybody else got anything?
And you said you're gonna post the rotations? So we can
do it right now.
So we can see who's in our group.
So you can see.
Oh.
Absolutely. I'll put it under modules. I'll put it under 439 modules. Now wait a minute, 436. I'll put it under 436 modules because it's clinical. Anything else? All right, you guys did good for the first day. It's a long one. Have fun tonight. Go do something just a little fun. And I'll see you at 10 o'clock on in the morning, same channel, same bat channel. And we'll get into chapter 2, okay?
Thank you.
Thank you.
Thank you.
All right. You're welcome. See you
Thank
tomorrow.
you.
Thank you.
Thank you.
I don't really know anybody who specializes in that, but I do know a excellent nurse practitioner who works in Orlando, and she's doing a lot of virtual therapy. I'd be glad to send you her name and number. I will keep my ears open.
She works out of a place on Robinson Street in Orlando called Everybody's Counseling Center. She's doing a lot virtually. I love her. She's doing a lot virtually. She's pretty awesome. You can check her out online. Online. She's a nurse, she understands. Yeah, he needs to focus on himself and not you.